Good morning, everyone. We'll go ahead and get started right at the top of the hour. I want to welcome you to our 2025 Hero Healthcare Summit. My name is Ryan Sledge. I'm with HCA Healthcare, and I have the pleasure of serving as the co-chair of the Hero Healthcare Summit, along with Amy from Ohio Health. And this year, we're really excited for this virtual gathering that we have and for the opportunity to talk about a theme that really is at the heart of the work that we do as healthcare workers, and that is promoting human connection in healthcare. If you've been a part of the summit over the past several years, you know that we've really navigated the evolving challenges facing our workforce, our healthcare workforce in particular, themes around emotional strain, themes around burnout, how we redesign work in the workplace, and the need for physical safety and mental health support. And this year, we'll be bringing all of those themes together and focus on what really can help sustain us in the middle of all of that, which is all about connection. And so we'll be exploring strategies that help us foster civility, caregiving, mental fitness, and build a more humane and resilient healthcare environment, both for today and for the future. And we are thrilled about the incredible lineup of presenters that are here today. We have leaders and innovators who are driving change across healthcare systems, in research and practice, and really will help make this real for us to help us learn how we can apply these concepts to our own organization. So before we begin, I want to extend a heartfelt thank you to our Hero Healthcare Summit Planning Committee that you can see displayed on the screen for their tireless efforts in pulling this event together over the past several months and all of the work it takes to inform a really strong agenda. And also to our event sponsor, Credible Mind. Credible Mind offers a digital platform that helps organizations support mental wellness across populations, and that's healthcare systems, health plans, employers, and more. And really, it's about meeting people where they are and giving them the support that they need. And that is a theme that I think beautifully ties to what we're gathered to discuss today. So I am pleased to introduce Eric Zimmerman, Chief Marketing and Market Solutions Officer at Credible Mind, who will be sharing a few words with us, and then followed by one of our planning team members, Dr. Martha Shepard, who will introduce our keynote speaker and get us started for the day. So Eric, over to you.
Ryan, thank you for that great introduction and for introducing a little bit about our company. I'm not going to spend much time there, but I'm going to make a few comments just to frame the day. I want to acknowledge you and Amy and the planning committee, and of course, Karen. I think this may be my 12th Hero. I'm not quite sure. I lost count at some point. I have to share, and I'm sure a lot of you feel this way. It's a little disappointing not to be together in person because if Hero, if nothing else, is a place for human connection. And I think we all treasure that time together. And we're going to do it this way this year. And I know we'll get a lot out of it. And I just want to acknowledge everybody for the resilience to be here today and to do it this way, given circumstances. The first thing I want to do, for those I don't know, I know a number of you, but not everybody. You're seeing me in a little bit of a new context. I think this may be the fourth or fifth different organization I've been with in the workforce health and well-being space. I'm really excited about this one for some reasons I'll share. I've been driven through my career over the last few decades by really a core purpose of operating at a systems level around health and well-being. I'm raised by clinicians. I'm not a clinician. I come out of a family of mental health practitioners. Somehow I avoided that, but I centered my career there from a public health perspective. And I really want to just share a little bit of data to start that was assembled by our chief medical officer. One of the things Credible Mind does is collaborates with the American Hospital Association, the AHA. This week, in fact, we're launching a whole educational series with AHA for hospitals around bringing greater access, dealing at a community level, the community of employees, the community out there, community of patients, and really looking to harmonize experience, because we know that when the issues that Ryan alluded to are in play, it's not just about the workforce experience, it's also about the patient experience. Data confirm that. We know that rates of burnout are quite high. They're over 40% among nursing staff, 20% intending to leave within a year. That is a sobering statistic. We also know that suicidal ideation is very high in healthcare, higher than the general public, at a 2x rate for physicians, and nurses likewise high, and even worse for medical students. So we have a lot of work to do, and there's a lot of work we can do to create that human connection that builds that resilience, creates some more civil workforce. One thing I learned early in my career doing a little bit of hospital consulting around health and well-being, and I learned this from the nuns at a Catholic institution, and you may have heard this saying before, no margin, no mission. So connecting this to business imperative is really key, and I know we'll do that a little bit today. It's estimated that there's about $4.6 billion in excess cost in physician turnover and burnout and reduced productivity alone. So this is a human issue and it's a business issue in a healthcare environment that's really strapped and stressed right now for resources. Just a little bit about Credible Mind. Ryan did a great job. We're probably the most widely distributed platform you've never heard of, mainly because most of our work has been in the public health sector with counties and cities and states creating greater access to evidence-based resources starting upstream. We all know that we cannot treat our way out of the mental health crisis in this country. We have to get upstream and apply public health principles. We've done a great job over the last couple of decades with cardiovascular disease. Rates are down by about 35% in terms of deaths from heart disease, but guess what? Rates are up from suicide. So we have to do some of the things we've learned how to do in other sectors of health with emotional and mental and social well-being. We call it flourishing at Credible Mind. We have a framework for flourishing that includes those elements as well as contemplative well-being. And ultimately, culture matters a lot. I know that's what this is about. I've often said that culture is an emergent property of how we treat each other. And so I know each speaker today will talk about that in a healthcare setting. We have a lot of work to do. I'm excited to be here to join the conversation. And if you want to learn more about us, as I mentioned, the American Hospital Association has an educational series you can join. If you happen to be in an academic medical setting, we're collaborating with Coupa in a couple weeks in Denver to do some educational work about how to bring resilience even in the face of crisis. So we've got a lot of work to do. Let's get about the business of doing it. Thanks for having us. We're just delighted to support this event. And I'll turn it back to Ryan.
And actually, I'll go right over to Dr. Martha Shepard.
All right. Good morning, everyone. It's so good to be here with you. My name's Martha Shepard. I serve on the board of HERO, and I've been a part of the Healthcare Summit Planning Committee. And I have the pleasure this morning of introducing our keynote speaker, one of my colleagues from Vanderbilt, Dr. Bill Cooper. So Dr. Cooper is a practicing physician, researcher, teacher, and administrator. He's led Vanderbilt University School of Medicine programs, including the Vanderbilt Health Center for Patient and Professional Advocacy, the Master of Public Health program, and the Pediatrics Office for Faculty Development. He's an internationally recognized expert in medication safety in children. He has published over 160 scholarly articles to date. Dr. Cooper oversees Vanderbilt University Medical Center's professionalism programs for physicians, advanced practice professionals, and nursing professionals. And he provides leadership and direction for the Vanderbilt Health Center for Patient and Professional Advocacy, which supports a national professional accountability collaborative of over 200 hospitals throughout the U.S. and in Australia with research, education, and professional accountability programs. So welcome, Dr. Cooper.
Thanks so much, Dr. Shepard. Really appreciate the chance to spend time with you. All the things that you're describing in the run-up to the HERO Summit around sort of creating a respect of culture, our culture of respect and safety and thinking about well-being aligns so much with the things that we've been up to here at Vanderbilt. And so I'm going to walk you through a little bit about sort of how our lens on this, particularly as it pertains with creating a culture where we talk with each other and not about each other, right? So that our work over the last 20 or 30 years has really given us a glimpse into the fact that the vast majority of our healthcare workforce comes to work every day they behave in perfectly wonderful ways. 90% or so. 7 or 8% occasionally stub their toe, but 2 to 3% of individuals create about half of the struggles that we face by how they treat patients or how they treat coworkers. Those same clinicians, their patients do worse. Physicians are at greater risk for malpractice. We've shown that they're at greater risk for burnout, difficulty with personal relationships, cognitive impairment. They affect the experience of our workforce in terms of driving sort of people who leave our organizations because of how they're treated by others. And so what we've learned is not only the fact that we can identify those individuals, but we have identified strategies that allow us to, using respectful, non-judgmental ways, actually turn that performance and those behaviors around. I'm going to share with you a little bit about that so that we can think as we look at the whole summit. It's such an exciting day, all the things that sort of align around our shared interests in supporting a culture of respect and safety and all the things that tie to that. So we'll be looking forward to sort of thinking through how do we approach that, because it is in our experience, it's such an important part of what we're all trying to accomplish together. And the idea here is that as we in our various roles serve as leaders, but also as we think about providing a right culture, how do we go about supporting each other and our colleagues? I have no significant financial interest. I am a practicing pediatrician. Pediatricians never have significant financial interest because nobody wants to pay us to do stuff. So that's a safe place for me to live in the financial conflict space. When we think, though, about how do we have our workplaces in healthcare be a place where people can't wait to get to work every day to do what they're trained to do, we know that to provide the highest quality care, we have to have intentionally designed systems. And you think about all the intentionally designed systems that live in healthcare, procedural timeouts. I practice in our primary care clinic at Vanderbilt. We have safety huddles every morning before we start clinic to talk about what's staffing going on, what vaccines do we have, what are safety issues we need to discuss. Checklists, scan codes, all the things that we have are good, really good intentionally designed systems. But those intentionally designed systems are operated and run by humans, right? And so if you ever think about how those of you who are in clinical environments or adjacent to clinical environments, sometimes you'll say, you know what, I'm just going in this patient's room really quickly. I don't need to wash my hands. I'm just going to drop some paperwork off. Well, that's an intentionally designed system, is having the foam dispenser by the door, the sign that reminds me, a policy about hand washing, feedback given. But if I elect not to do that, then we have to find the right way to get everything that's done for the systems, but also to help hold people accountable. And when we say accountable, we're not hammering people over the head to say, hey, do this right. It is, gosh, I just want to let you know, we share a vision of having the best outcomes for our patients. And I just thought you'd want to know this quick thing that I observed. And you look over on the right there, that's an image of Semmelweis, who really showed the impact of hand washing on reducing maternal and infant mortality how many years ago? And the intentionally designed system that Semmelweis put in place is that basin that you bring to the bedside. But if people don't stop and wash their hands, it doesn't work. And are we really still having to talk about hand washing how many hundreds of years after Semmelweis made his observations? So what we're about is, how do we go about this in a thoughtful way? Well, we've been doing the work that Dr. Shepherd described for about the last 25 or 30 years. And we have found various sources of data that allow us to identify individuals that may be at risk for struggling with performance in terms of how they treat their patients and coworkers. I show you here some data that we collect through our national collaborative from unsolicited patient complaints, not patient satisfaction scores, but when somebody's unhappy enough to pick up the phone and call and say, hey, I didn't have a really great experience. And so in that, we get these patient complaints. All of the health systems around the country have a process for capturing grievances and other complaints. I heard Dr. Y yell at the staff before the procedure. Is Dr. Y always like that? I saw my doctor for back pain. Another PCP said I needed surgery right away. They were right. I was asking the nurse practitioner about my diagnosis, said that my questions were annoying, and Dad told Dr. W it was difficult to breathe. Checked him out briefly. So it was just a cold. Next day was in the hospital with pneumonia. These are real stories. I haven't made any of these cases up. But what's interesting when you think about healthcare, the hero work through the lens of patients, these are times where we fail to meet or exceed their expectations. Sometimes they get it wrong. Sometimes their perceptions are just flat wrong. But when we take these data and use them to guide how we improve our systems and improve the performance of individuals, they can be really powerful helpers for us. Similarly, we collect safety event reports from the 300 hospitals in our national collaborative that describe sort of behavior that's not really consistent with creating a culture of safety and respect. The APP came into the room and did not foam in. During the timeout, Dr. B said, "Hey, keep going, I'm listening." Offered the nurse practitioner a pair of gloves, said, "No, thanks," dropped them in the trash and continued. I attempted to give report to the nurse 3 times via phone. The nurse refused to come to the bedside for report. So these are times where our interactions with each other aren't necessarily creating a great space. And in the research we've done, what we found is that when you look at patient complaints on the left and coworker concerns on the right, just as I described at the beginning, the vast majority of individuals never get any. This cumulative distribution I show you in these 2 curves. For example, when you look at patient complaints, 50–60% of physicians and APPs never get any patient complaints. 25 to 30 get an occasional one, but 3% or 5% are accounting for almost half of those. In the coworker side, those interactions among coworkers, 3% of individuals are accounting for almost half of the reports, whereas 90% never get any. So this idea is that what can we do to help those individuals be the best version of themselves in support of what we're trying to get done? And why does it matter? I'm an epidemiologist, and so we've been able to link our data to National Surgical Quality Improvement Program data, a large well-being cohort that Tate Shanafelt runs on the West Coast at one of our sites. We've linked them to National Trauma Data Bank data, to ACGME data, to really gain insight into not only the fact that these behaviors exist, but do they matter? So what we found is that patients whose surgeons have a large number of unsolicited patient complaints, or in a separate study, a large number of coworker concerns, those patients are 20 to 30% more likely to develop a surgical site infection, 20 to 40% more likely to develop sepsis. And in team-based care, we often, the really important work you're doing through HERO is about ultimately promoting sort of that we are a team working together in the service of patient and our organizational goals. But in trauma care, which is a great example of team-based care, right? So trauma patients require multiple services. It only takes one service with a disproportionate share of individuals who behave in unprofessional ways out of the norm to account for a 24% increased risk for mortality for trauma patients. So trauma patients who are cared for by 5 or 6 services, if one of those services has a bunch of physicians who behave unprofessionally, just one, those patients have a 24% increased risk of dying. Our studies over the last 25 to 30 years have also shown that these same individuals account for 50 to 70% of an organization's malpractice risk. In the business literature, Phelps showed that these team members have a ripple effect where they have increased negative behaviors, withdrawal, anxiety, and jousting, and decreased positive behaviors of creativity, learning, and motivation. And how does that play out? You know, we think about this, what's happening to lead to these worsening outcomes? Because all we're showing in our epidemiologic studies is an association, not a causal relationship. If you look at cats, the study by Katz on the left and the study by Riskin on the right, in the Katz study, they took an OR simulation and exposed the team to dismissive behaviors. This is, you know, actually somewhat civil behaviors of just being dismissive and not screaming, not yelling, not throwing stuff. And when they looked at the performance of the anesthesiology residents in those simulations, individuals were 4 times more likely to underperform because they didn't pay attention, they didn't communicate, and they didn't model teamwork. In the right, in a pediatric space, in neonatal intensive care units, Riskin showed that exposing teams to similar dismissive behaviors resulted in them not paying attention, them not offering help to each other, and not communicating. And each of those teams was more likely to underperform in a randomized controlled trial. So the approach that we've taken over the years is to identify individuals and have a chance to talk with each other, not about each other, and not wait till disastrous things like malpractice claims, burnout, and other things develop. We want to meet people in a preventive mode. I'm a pediatrician, right? So I come to work and think about preventing things, just as you talked about, right? So instead of taking a reactive posture, what can we do to help our colleagues? Well, what we find is that when you appeal to healthcare clinicians' sense of self-regulation and professionalism by just saying, I know you know what you're doing. You're an outstanding clinician. I just want to let you know that for some reason we're seeing this signal. And so our tiered intervention here allows us to share information with those individuals who exhibit these behaviors. So for example, when a single event comes in, we get a coworker concern through our electronic safety reporting system. What we do is we first look to make sure it's not one of those red triangle events, right? Violence, discrimination, impairment by drugs or alcohol, sexual harassment, sexual molestation of a patient. Those are things that get pulled out and addressed through law, regulation, and policy. It's about 4 or 5%, but 95%, what we find, no matter if we think the patient got it wrong, or no matter if the nurse should have called somebody else up the chain of command, if we'll just sit down and have a peer have what we call a cup of coffee conversation with the individual, 97% of the time they don't do it again. And I'll show you what that looks like in just a minute. However, if they are in that 3 to 5% who account for half of that because they have repeated instances of an apparent pattern of behavior where when we benchmark them against their colleagues, they're outliers, why then we step up the intervention and do what we call an awareness intervention where we give them benchmarking. Say, gosh, when we compare you to other thoracic surgeons or other primary care pediatricians or other gastroenterologists, for some reason your practice seems to be different. And that works about 87% of the time, even for those with pattern. We're ready though, if they don't, we move up the pyramid to now we put corrective action plans around them. And depending on if they're a staff nurse, we would follow an HR, written warning or final written warning or whatever the process. For physicians, we might use a medical staff process such as focused professional practice evaluation. For those with other relationships, whoever has authority over the relationship now puts a performance improvement plan in place with this person. And we can still rescue about 82% of those. And if not, then they do need to unfortunately move to formal action. But instead of taking people out and firing them, or just putting up with stuff for 25, 30 years, we find that this preventive approach can be quite effective. And I show you that here. The PARS work, that's the patient complaint work I showed you. We've tracked a little over 150,000 clinicians. We've given cups of coffee to 73,832. I am one of those people. I got a patient complaint once. It was November 14th, 2002, and I do remember it. And I was following what I thought was the right antimicrobial prescribing guidelines by not prescribing antibiotics for a child with an ear infection. I did the right thing clinically, but the grandmother disagreed. And when the mom got home, grandmother said, hey, let's go to Walgreens and fill Susie's amoxicillin. The mom described what we talked about and the grandmother disagreed, called Vanderbilt and told them I was an idiot. Well, that kind of hurt my feelings, right? But I was able to incorporate that into my practice and I don't get any more of those complaints. And I'm still standing. It did not cause me grave moral injury to receive feedback about how my patient perceived what I did, because it was done with me in a respectful way as a part of my growth and development. You can see on the cores, the coworker side, 160,000, 14,000, or about 8.5% have gotten feedback through that cup of coffee. As you move up the pyramid, you can see smaller and smaller numbers, because each time we do these interventions, fewer and fewer people persist. The very top, though, those who never responded to cups of coffee awareness, authority-guided intervention that went on to require formal action, that 125 plus 18 is 143 people. Among that were 5 previously undiagnosed brain tumors, 25 with early signs of cognitive impairment. And how will we know if we don't engage? And so our work is about getting there and helping people. Strikingly, using patient data and coworker data, identifies different people. So the patient complaint side, if you're identified as having a pattern of patient complaints, only 8% of those also have coworker concerns. I don't know if any of you have ever had the pleasure of working with a narcissist, but a narcissist clinician says, Angelica, you are so lucky you came to see me. I, William Cooper, am a super good doctor. I trained a long time. I'm really smart. And Angelica, I'm so glad you came to see me because I fixed you. Now, Angelica, I do have to tell you, my partner, Dr. Eric Zimmerman, unfortunately, he is an idiot. So only come see me for follow-up because Dr. Zimmerman will kill you and undo all of my hard work. I told you I don't make these cases up. I'm not making this up either. So the narcissist doesn't get patient complaints. They don't do so well on the coworker side. Let me just walk you through a case. Let me just show you how this works. So Frank is a surgeon. And Dr. Frank walks into the OR and said, you know what, I tell you what, we're all on the same page. Let's begin. The anesthesiologist appropriately responded because this hospital has a timeout protocol. We need to do the timeout. Dr. Frank says, oh, great. I'll step out and answer a few pages. Let me know when you're ready. This was a civil response, I would argue. Not consistent with safety expectations, but walks out with a smile on his face. Now, I want you to get your phones, if you will, and go to this QR code and enter. Do you think this is a threat to safety? Our work, as we're talking today, Hero is about creating safety and respect. Is this a threat to safety? All right, what are the reasons why it might not be a threat to safety? Well, you know, the team did the timeout, right? Without Dr. Frank. Does Dr. Frank know for sure that they're about to do the right procedure on the right body part that was marked and everything else, and this patient been consented? So one of the things is it's a potential threat to safety. And so when you think about how you might answer here, but nonetheless, we generally agree that it's on the side of potentially being a threat to safety. If this occurred in a healthcare setting where you've either practiced, received care, or with which you've been affiliated, what percent of the time, if Dr. Frank walked out of the operating room, would someone speak up or report the event? I'll put the QR code up in case you have your access to your phone. Well, what do you think about this? Like, vast majority of this thought this was probably a threat to safety. Yeah, when we think about how we as our work here as a part of the summit today, we're about creating a culture of safety and respect where we talk with each other, not about each other. What the heck is going on here? Because what we're after is how do we empower all of our team members to, with respect, engage with each other. Let me show you what a cup of coffee looks like. So in the work that we do, when this event came through, it would be processed and a peer messenger would be dispatched to have a conversation with Dr. Frank that would follow the cup of coffee. And so what I want to do is show you what that looks like. And I've enlisted Dr. Sarah from UC Davis, who's one of our later speakers, to be Dr. Frank in this setting, where I'm going to show you what a cup of coffee looks like. So if we can spotlight Dr. Sarah and me, we will go. Good morning. I'll call you Dr. Sarah just to sort of keep it clear for us. So, you know, Dr. Sarah, do you have a second to talk?
Yeah, sure. What's up?
Yeah, I really appreciate you taking time. And I know you've got a busy operative schedule today, and I just appreciate you chatting. Now, Dr. Sarah, I am a member of our health systems professionalism committee, and anytime we get a report about an interaction that sort of creates any concerns, I want to get out and share that with people. And just want to let you know that we got a report about a case you did yesterday, and it says that the anesthesiologist called for the timeout, and apparently what happens is that the report said that you sort of said, great, you then kind of walked out and didn't participate in the timeout. Love to hear your side of the story.
Yeah, I thought we were all on the same page and I felt pretty confident. We all were agreed we were there for. And I don't know. I just, it's one of those things, like the checklist stuff that you got to do for the OR. And I'm busy. I'm busy. I had like a bunch of pages I had to get to. I didn't really think anything of it. No one seemed to mind.
Yeah, well, and that's great. And you're an amazing surgeon. I know I've referred a ton of patients to you, and people respect you so much. The main thing I'm bringing this up for is that we have decided as an organization that timeouts are a really important part of avoiding wrong site surgeries, to make sure we're all on the same page here, to have the team know each other so we can work well together and sort of be in that space. And I'm just wondering, the next time you have a case, even on a busy day, if you could sort of just kind of work with the team on sort of modeling that, because so many people look up to you.
Yeah. I mean, sure, you're right. Yeah, I've got, residents and fellows who are in there and I don't want to get dinged for it. I mean, I guess my question is, am I in trouble? Is this like, am I going to get an IR or like
Oh,
going
yeah.
on my record?
Thanks so much for bringing that. No, this is a time for us to share this. Now, we do record this as a part of our professionalism approach here in our health system. And, I'm confident what we find is 97% of the time, once I have a conversation like this, or any of our fellow members of the professionalism committee, it doesn't go away. The reason I wanted to come is because I respect you so much, and I just appreciate your time today. Have a great rest of your day.
Yeah, of course. No, I appreciate you bringing this to my attention.
Thanks, Dr. Sarah. That's it. That's what a cup of coffee looks like. Thank you so much. Let's give a round of applause for Dr. Sarah for,
Thank you.
Unfortunately, the Emmys have passed. We're going to have to wait another full year to see whether this performance in sort of a lead role is going to be sort of result in a trophy. But the idea here is the cup of coffee wasn't me saying you're a bad doctor. You didn't follow the timeout. I didn't accuse Dr. Sarah. I said, gosh, wanted to know, she did appropriate pushback, right? So she did, you know what? I didn't think it was a big deal. I'm super busy, all the things. And what I was able to do using the skills I've learned as a trained messenger is to say, I hear you, and just wonder if it could go differently. That's all that takes. What I just showed you is exactly how these work. So, unfortunately, Dr. Frank is not one of those responders and continues to generate signal. The nurse reported Dr. Frank broke scrub prior to the closing count. Contacted Dr. Frank because our policy says stop the procedure and get the count right. Dr. Frank said, keep going, just get an x-ray. Nurse reported Dr. Frank was positioning the patient before intubation. The RN was still plugging in equipment. Dr. Frank began injecting local. The timeout hadn't even been performed. The third report, I asked Dr. Frank about changing gowns and gloves as a part of our surgical bundle. So we all do the same things every time we do a certain type of surgery. Dr. Frank said, I don't really believe it makes a difference, and did not stop. Now, what do you notice about the themes here? Rushing through. Dr. Sarah already told me how busy Dr. Sarah was. What we are able to do is provide, by benchmarking Frank at this awareness level, is to have an awareness conversation to say, gosh, Frank, I know we've talked before, but now there appears to be a pattern. When we compare you to, 50, 60,000 physicians, for some reason, this yellow dot is you, and 98% of physicians have fewer of these coworker scores than you do. And out of 1,793 general surgeons in this national data set, you're in the top 100, and I just thought you'd want to know. That actually works 87% of the time. Dr. Frank is likely to give me very similar pushback. I leave the data with Dr. Frank to reflect, because professionals self-regulate. When a new antibiotic prescribing guideline comes out, I change my practice, because that's the standard. In that awareness intervention, we also provide local comparisons and all these other things as a strategy to give the best chance. Now, I said 87% report. For our purposes, Frank's going to be one of those that doesn't improve. I asked Frank to give me a couple minutes to start an outline. Dr. Frank rolled his eyes and started whistling the Mickey Mouse theme song, always rushing us. No need to change gloves. The whole case is dirty. The patient seemed confused. I asked Dr. Frank if we should wait for the patient's spouse to sign the informed consent. Frank said, no time for that. He's fine. And you can see we're able to track Dr. Frank over points in time. The first intervention at point A, still generating signal at point B, still generating signal at point C. We now have not a single cup of coffee, not an apparent pattern, but we now have a real pattern. Where now Frank's boss is going to sit down with Frank and say, gosh, for some reason, you've had a lot of chances to self-correct here, Frank, and it hasn't worked. Now we're going to come up with a plan that's going to help you be the best version of yourself. And if Frank's a member of a medical staff, this would be the focused professional practice evaluation. If Frank's employed as a part of an employed group and as under a professional services agreement, may get a performance improvement plan. Whatever it is, whatever pathways we have, we're going to use that to ensure that we put a little more boundaries around Frank to improve Frank's performance. Now, oftentimes, those of you who sit in healthcare know that this is hard work to do. It's not for the faint of heart. And Dr. Frank may generate a ton of revenue for our health system. How many times have you encountered times where health system leaders blink and they say, gosh, this guy generates a lot of revenue for us and we built this new OR for him. Are we sure this is the right time? In that, what we really encourage us as leaders and all our health system leaders to do is to say, yeah, but let's think about all the key stakeholders here. How about the patients who may suffer increased risk for quality outcomes or bad quality outcomes if we don't do something about this? How about the wrong site surgery because Frank doesn't participate? How about the patient who got injected before the procedure was done? On the other side, you've got coworkers. When you think about the anesthesiologist who called for the timeout, Frank walks out. How many times is that anesthesiologist going to speak up before they give up? Is it one time? No, probably not. Is it 3 times? Maybe not. At some point, they stop giving up and they stop doing the timeout. You also got in the background the needs of the organization. So if I stop and I say, gosh, you know what? Frank's super special for us, a lot of revenue, new OR, and I just take a Frank-centered approach, what am I leaving on the table? The rights and opportunities to help our patients, our coworkers, and our organization. So this balanced approach to accountability is not a weapon. Accountability is something that as professionals, we all need to help us recognize how we can be the best version of ourselves. One of the things we find is that when you get to this higher level of these types of interventions, taking advantage of as much data as you can be really useful. I show you here Frank's progressive increase in coworker signal. At our organization, I lead our peer review, our ongoing professional practice evaluation, and we created this dashboard. And look at Frank on our dashboard. Frank is pinging in the coworker observation space. Lo and behold, Frank has more surgical site infections than peers. Frank also doesn't participate in required quality improvement initiatives like morbidity, mortality, and improvement conferences that all of our clinicians are expected to do. Frank doesn't do training on patient customer service. And those who work in sort of clinical settings know that whenever I'm on service, I get a note at the end of my time on some of my patients that say, hey, Dr. Cooper, you admitted this patient who seems to have dehydration because their mouth was dry, they had a high heart rate, and you gave them some IV fluids, but it doesn't say dehydration. If you can document this, we're able to have full documentation of the care you delivered. If I write a snarky note back to say, you're not a doctor, I am, 90% of people respond to the coders. 7% are occasionally miss, 2% account for 50% of our misses. Does that statistic sound familiar? Frank is pinging across multiple domains. And as we think about the best way to help Frank, we need to consider where this performance might be coming from. Frank also has a malpractice claim. The stapler misfired, the patient developed sepsis, renal failure, low blood pressure, had to go back to the OR and still has chronic abdominal pain and diarrhea. So now you've got malpractice claims. professionalism concerns, patient outcomes, citizenship, documentation concerns. This authority-guided intervention really can take on two forms. Remember, I told you about the cup of coffee, and Dr. Sayre and I demonstrated that. A cup of espresso is a single event with the leader that says, Angelica, tell you what, here's this event. We're gonna talk about this. This is the last one of these conversations we're gonna have. And Angelica, I'll be following this up with a letter. So that is a big deal. We call it espresso. Or the organized, fully developed corrective action plan when there's a pattern is shown here. This is not sort of a checklist of things, but an opportunity to know that our leaders, we can resource our leaders to help give the right resources. So these are the things that a plan for Frank might include. Here's our expectations in our health system. Here's where your discrepancies, here's the data that support that. Here's what we're going to do. And our recommendation at this point is that every single one of these individuals gets an evaluation of how they're doing through our employee assistance program to identify resources to help them improve their performance. I am not making a diagnosis, nor do I have a physician relationship with Frank to make that diagnosis, but Frank may be struggling. What's going to happen if this doesn't get better? How long are we going to do this, and how will we know it's getting better? We have identified and sort of thought about what are the resources that we can come to help when we're looking at either Frank having a performance challenge, as Betsy Williams has described in her work, a capacity challenge, or a capability challenge. Each of these things are levers that we can use, because now Frank has moved from individual self-reflection and regulation to now needing some additional help. Now, what's really interesting is those of you who sit sort of and think about the learning space, Frank is 16 months into practice. Guess what? You'll look back at Frank's performance as a trainee. As an early fellow, Frank had similar types of behaviors. As a senior fellow, Frank had similar types of behaviors. Continued through, and guess what? When Frank transitioned 16 months ago, it didn't magically get better. So what are our responsibilities in our hero space for our learners? When our learners are underperforming and we just check them off, look at this. Because look at Frank's ratings the last cycle. Green, 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 green. Just great. Head on. Whereas every stage along fellowship, Frank was underperforming in professionalism and communication skills. What do we have responsibilities to our organizations and as teachers, those of us who play that role, to ensure we help our individuals be the best version of themselves? In this case, Frank's leader did refer for an evaluation of his performance and to identify resources to help him improve his performance. Turns out there were some underlying challenges. An unspecified anxiety disorder, cluster B personality traits, other challenges, financial concerns, and significant family stressors. Now, I've lifted the veil here. As a leader at Vanderbilt, I don't see this information because this is private between the treating clinician and Frank. But I show you this to let you know that individuals who get this high often do struggle. We've done work with Tate Shanafelt and others showing that physicians who are burnt out show up with unprofessional concerns. Physicians who have difficulty with personal relationships show up with professionalism concerns. We've done some work showing that you can actually, early signs of cognitive impairment can be picked up in words that patients use to describe their clinicians. Physicians with cognitive impairment were 20 times more likely in this study to have words like, my doctor was forgetful, my doctor was confused, my doctor came in and made inappropriate jokes. That signal that's not causal and doesn't mean we rush someone off, but it just tells us something is going on here that's different. Frank was able to get resources that included adjusting things in Frank's practice, giving Frank insight, giving Frank resources and skills to navigate the anxiety that was driving this need to push through. Frank was able to do that. And after interventions over the past 4 years has shown improvement and dropped the number of coworker concerns that Frank has received. So all the stuff we've talked about is there on LinkedIn, and just a chance to sort of all the research that we publish, all the papers are there, just as a way to sort of guide how we think about stuff. And want to stop and give plenty of time, because a lot of the value of this, and even in a virtual space, is having dialogue. And so either in the chat or in person, anybody want to sort of raise questions or share other experiences as we learn from each other today?
Dr. Cooper, I will go ahead and chime in and say, let's table that. I think, yeah, one more cup of coffee might help people. So as we think through those things, I'd like to shift us to our panel, if that's all right with you.
Of course.
Wonderful. All right. My name is Cindy Baylog. I am privileged to be a part of the Healthcare Summit Planning Committee. So I am going to introduce Dr. David Hurtado. Dr. Hurtado is an associate professor at the Oregon Institute of Occupational Health Sciences within Oregon Health and Science University. Dr. Hurtado leads workplace interventions to improve healthcare worker health, safety, and well-being. He designs and evaluates semi-structured interventions, flexible yet guided practices that can be adapted to real-world clinical environments, such as leadership check-ins between supervisor and staff to reduce burnout, improve supervisor support, and strengthen values and alignment. His research focused on healthcare settings is funded by AHRQ and NIOSH and has received national recognitions for its applied impact. Dr. Hurtado earned a graduate degree from Harvard T.H. Chan School of Public Health and has authored over 40 peer-reviewed publications. So thank you for that. And I'll go ahead and turn it over to Dr. Hurtado.
Thank you so much. I am delighted to be here. Thank you so much for the invitation. We want over the short, right? You know, that was an excellent presentation, Dr. Cooper. I learned so much in the organizers of this event. I think put together two complementary presentations. Will be shorter. My presentation will be shorter. And what I'm trying to focus today is on the practical aspects of conducting leader team member check-ins. And as we have been talking throughout this morning, burnout is one of the most urgent concerns in healthcare. It's been a longstanding issue. And the last years of struggle with the pandemic and the post-pandemic have only added more salt to this psychological injury. However, what I hope to present today, my contribution is hopefully be to showcasing a very practical, easy to implement practice where you can see how having brief and semi-structured check-ins between leaders and their team members can help reduce some of these problems. So I don't want to get too much into this because I want to say it's a topic that we agree on, but the reason I focused on the pandemic burnout drivers is not just because of their significance, but because the journey for this research started also in 2020. So in fact, our first pilot grant was awarded on March of 2020, and if you remember, that's when everyone on this planet was making adjustments to their lives and their work. So and that was certainly the case for this line of research. But when we were thinking of burnout in that time, it was all about responding to the crisis and adapting to the crisis. However, as the as time move forward, the new normal, quote unquote, is not necessarily easy either. And many healthcare facilities are coping and bracing for ever changing financial and policy landscape. So on top of the emotional burden of responding to the crisis, then we have these new chronic issues in terms of admin burdens and financial woes. So the healthcare workforce in general, it's been reeling, and urgent solutions are definitely needed. But once you have this systemic, multifaceted problems, the issue from an organizational and an interventional standpoint is, okay, where do you start? And I come from organizational health sciences, and we always talked about organizational reforms and system policy reforms. But the issue of starting there is that it's a more complex, and it's not going to take it's not going to be a fast acting level of intervention. It's the goal, but certainly a difficult starting point. And but at the same time, you need to transcend individual level approaches that will be limited in making these changes to culture, to policies, the very things that we start talking this morning. And at the team level, yes, you can the teams is where the culture and the norms and the values are shaped, but you can only go as far. However, with what we identify in our research and theories is that leaders at multiple levels are the ones that intersect the different structures. So those can, if interventions are focused on organizational leaders, then you can interlink different levels and have a greater impact and an easier route to implement the changes that you want to see. So why focusing on team leader member intervention is important? Because sometimes it's just, and the presentation that Dr. Cooper just did is about, sometimes it's in the relationship that you establish with team members is when a lot of these problems come about. And sometimes it's not just about individual members, but how the behaviors of individuals really illustrate the problems behind the organization. So sometimes it's not just it's relational and not just structural, or said in other words, in the behaviors of people, problems of the structure are manifested. So that's how the relationship is how you unearth these problems. As I mentioned, it's agile and actionable. So sometimes we call for revolutions, but the revolutions will take time. And something that I found somewhat frustrating is that, if you want to implement a change in healthcare, everyone says, yes, you need like buyout from senior leadership. And then, okay, let's have a meeting with the CEO, and the CEO is not available. Or it's only available on the last Wednesday of every month from 10 to 11 a.m. And, you will have, 5 minutes in the agenda with other items. And yes, I think, and sometimes, healthcare organizations and organizations in general want to set a priority, and then they form a committee, but the committee never meets, or the committee has this listening phase, and then recommendation of a task force and whatnot, and nothing really happens. So focusing on the leaders of teams, it's faster, easier to implement, and it's actionable. And as I mentioned, leaders and their teams, their behavior demonstrate the impact of other interventions and the culture in general. So a good barometer of a culture, just focusing on behaviors that happens within teams. And as I will explain later, focusing on team leaders both addresses the acknowledgement of problems, but also gives them a very direct cues for action and improvement. So I mentioned that our first pilot study started in 2020, but the reality is that we had some surveys conducted before the pandemic, and this whole check-in path started with a simple observation, which was my colleague Abby Lenhart at OHSU was surveying primary care clinics in terms of emotional exhaustion and other psychosocial variables. And there was one clinic that, contrary to the rest of the clinics, was doing better one year after in terms of emotional exhaustion. So whilst the trend of OHSU at large was increasing emotional exhaustion, there was this clinic that was able to reduce burnout almost in half. So obviously that caught our attention. And when we were making sense of the data, we went to the clinic and said, hey, is there something that explained this trend? Because it's very unusual. And turns out that there was. So that's how we discovered the check-ins. By the way, as a researcher, it's much easier when you try to have something that was organically done at one clinic or one practice and then try to replicate it elsewhere, as opposed to you come up with the solution that you want to convince an organization to implement. So that was our first observation, that if this check-in practice is promising, perhaps we can replicate it elsewhere and make it as a best practice and evaluate its effectiveness. But before we try to replicate that experience, we first need to understand what this experience was about. What is this check-in? So what we learned through qualitative methods was that these check-ins were created by the newly appointed practice manager, and she just wanted to just learn her team much better. So that's why she started implementing the check-ins. And the check-ins is not a concept that we invented or this practice manager have invented. Not at all. So many organizations since forever have one-on-ones or different type of personal interactions. But what is unique here is the scope and the frame in which these check-ins were conducted. So these were one-on-one meetings between the supervisor and the worker. At that clinic, they were happening roughly once every 4 or 6 weeks at an office or a cafe. So very similar to the cup of coffee concept that Dr. Cooper was presenting. They were private and confidential. And in fact, they, in the interviews that we conducted, the person mentioned that we had the Vegas rule. So what is discussed in the check-ins, stay in the check-ins, unless obviously it's a reportable event or require the input of someone else. So if with permission, you could escalate the issue to a third party. And most importantly, it was not a performance review. So that meant that the supervisor or the team leader would open the check-in with an ample question like, what's working, what's on your mind, what can I do for you, right? So it was similar to the cup of coffee concept that Dr. Cooper was presenting, in that it was like a one-on-one, very conversational. But the difference is that this was much open, not incident focused, and just get a sense of what was important, what was working on what was important to bring to that conversation. So here's a rough sketch of how the process play out. So this was the team leader and their team member, and it was very important that they address what they can, and meaning that if there's a problem that is within the control and the power and authority of that team leader, then it was upon the team leader to implement a solution for it with the input of the team member, right? But for many systemic things that were outside the direct control or influence of that supervisor, it was so important that it was acknowledged, that it was documented. And that's when the listening part of the check-ins became so important. So we, in our qualitative interviews, we had so many quotes that speak about, I know that my supervisor cannot change this, but I felt heard. I was able to speak up. And as opposed to just assume that, this is a problem that you just have to deal with. So for the problems that there were a solution, if they required the input of a third party of higher ups in the power chain, then the supervisor would ask the permission of the team member, and they would escalate the concern. They would all brainstorm solutions together, and they monitor the implementation of that solution, and then they would meet the next time. So it was a very low key, not very structured QI cycle in that sense. But the fundamental idea here was to solicit input from the team member, address what you can, and document what you cannot, and acknowledge. So one thing for me as an organizational researcher that caught my attention is that even though these were one-on-one interactions, the changes were not individual level changes, but somewhere above that level. So for instance, from our interviews, we learned that what was discussed in the check-ins were things, for the most part, within the control and the authority level of the team leader. So career path recommendations or leadership training. So a lot of the conversations, the check-ins were like, I like my job, but if there's a way that I can expand my skill set, then I would be, I would appreciate it. So in many ways, the team members didn't have the information that was available within the organization. So the supervisor would say, hey, we offer this training, or why don't you, this other organization offers this training. So that's that was a good way to support the career of that person. Before the pandemic, it was all about facilitating flexible work arrangements. So we learned that one of the, and this is probably where the word life name come from, that even though it was not a performance review, many aspects of the work-life interaction came about. So people had a chance to explain their situations or describe the situation to the supervisor, and some problems from the work-life domain that perhaps were affecting performance. So facilitating telework or changing work hours, PTO, things like that was also a common topic in these check-ins. Improvement to processes, so that's a big one. And we had so many quotes we did these interviews in the fall, so there were a lot of suggestions about, for instance, vaccination clinics and things like that, where the team member said, I have an idea because I have to do my job, and what if we change this process as opposed to you tell us what to do? I'm telling you what works and what doesn't from my experience. So some team leaders were able to incorporate those suggestions and change the procedures, and changes to the work environment, like the workstations, lighting, temperature, things like that, that you may think that those are trivial, but when you have to do your job on an uncomfortable workstation, then it's not trivial at all. And that's the solution, is just a phone call away. It doesn't require like a full systemic change to get a new work unit. So that was the recipe that we were trying to replicate in a large randomized controlled trial, but we knew that this was a relational feature, so it was very difficult to try to replicate the secret sauce, so to speak. So we tried nonetheless, but in order to get to that replication standard, we provided structured training to the team leaders at the clinics that were randomized to the intervention. So we had 3 training modules, online training modules, to explain what this concept of check-ins is about, and how to demonstrate supportive leadership and the basics of QI cycles. Because once you hear problems, the important thing is to address those problems. We also gave them resources in terms of templates with instructions for check-ins, how to follow up via email with templates, and career resources and well-being resources for employees within the organization and outside the organization. We're in the process right now of making these templates and resources available to the public. So please contact me if you're interested in accessing these trainings and templates. But as is often the case when you do applied research, life gets in the way, and we did this randomized control trial perhaps at the most turbulent times within our organization, where, essentially the organization collapsed at the leadership level, at the senior leadership level. So from the president resignation to mass layoffs. And that's very difficult, not only for a study, but that became the least of the problems when you're trying to do research in favor of the health and safety of the workforce. But so obviously that affected the experience and the ability to collect data. That said, though, we're in the process of publishing all these results, but we were somewhat frustrated that our intervention did not find significant effects However, some of the trends are positive, and the reason why we didn't find effects, some part of it is that we just lost people to the survey. So the power was affected, the statistical power was affected when you have, mass layoffs. But at any rate, so emotional exhaustion, it seems to improve, or at least there's a positive trend. But we found more significant effects in these variables that reflected that quality of the relationship between their team leader and their team members. So healthcare workers at primary clinics felt that the supervisor was more supportive, and more importantly, that they felt that we're on the same page in terms of values. And we know that in healthcare, being aligned in terms of values, the positive value of healthcare is the human aspect of healthcare is so important. And you can see similar trends in family supported supervisor behaviors. This is a concept that just speak about how your supervisor is willing to accommodate and even role model work-life balance and supervisor support. So despite these positive trends, this is a quote from when we're enrolling participants, when we were touring each clinic to talk about this study. There was one team member that says, well, this seems like an interesting concept, but I hope your study fails. And not because I wish you ill, but because, we don't want, like, if your study is successful, then it's going to be yet another thing put on supervisors. And we need, it's all about giving them more resources, supports, so that you don't have to mitigate all the problems with a good relationship. So relationship can only take you so far. And I think that's a point well taken, and I agree with that. Nevertheless, I think that the reason why the check-ins work is because they were an opportunity to build trust and value alignment between team members and their team leaders. It was a way to demonstrate commitment to workers' well-being and safety, to implement changes based on worker feedback, and just put a very low-key QI cycle in motion where they can see where everyone was accountable to each other. I want to thank my team. Here's my contact information if you're interested in accessing these resources. And I want to thank the Oregon Healthy Worker Center, which is a NIOSH Center for Excellence for Total Work Health. So thank you very much.
Wonderful. Thank you so much, Dr. Hurtado and Dr. Cooper. Great information that you both shared with us this morning. So I'd like to facilitate our panel discussion. I will go ahead and kick it off with a couple of questions, but also want to open it up to the audience as well. So feel free to let us know if you have questions for either of them. So my first question is for Dr. Cooper. So Dr. Cooper, for Dr. Frank, for individuals like him who really struggled in training, to make that smooth transition to independent practice, what are ways organizations have found to help people like that?
Well, I think one of the things is having so first of all, having a set of values that says, it means something to work here, and we're going to hold each other to that, and that we really propagate that. And to Johnny's question, or Johnny's question in the chat, it really is about from the very first day of medical school through training, through new employee orientation. We talk about at Vanderbilt, we have what we call our credo values, is that typical sort of respect, courage, compassion, those kind of things. But it was woven into what we do. So setting that values is really key. Then that gives us a North Star to say, this is where we are. Not sitting around and waiting until something bad happens, right? So if I come in and I say, Cindy, 17 people have told me how rude you've been to them over the last few months. That's not helpful to you. I need to come and talk with Dr. Frank the first time that timeout is violated, because then that gives Dr. Frank the greatest chance to reflect, because it's recent. I didn't go out and investigate and look at the videotapes to make sure that Frank did actually walk out, because if he says he didn't, I don't care. It's really about giving that feedback. So that and then the ability, one of the things that we often will see is that people will say, yeah, we know this cup of coffee, we do that. And when I ask them, they'll say, yeah, well, we did 32 cups of coffee to Ryan Sledge and it didn't help. right? So you also have to have the willingness and the courage and the infrastructure to support escalation, as we showed with Frank's case.
Yeah, that's great. Thank you so much. All right, Dr. Hurtado, I have a question for you. What would you say is one simple leadership practice that strengthens teamwork and well-being? And what should leaders stop doing to make room for it?
Well, it's a tough question because there's nothing really simple, you know. But I would say that um, listening is not simple, but it's so important. So I think that uh, from this check-ins experience, for instance, the foundation is listening, and in order to get to that space, there are some requirements. One is to feel there's a minimum requirement of psychological safety that you can speak up and talk about things, but you also need to feel listened when you speak up and feel and say things. And then the other requirement is, and to your question is, if you listen, stop the problem solving mode for a second, and just the problem ID mode, turn it on. I think, but I mean, it's not a trivial thing, and listening is very difficult. Like listening with every sense and listening in preparation for action, but not yet. Uh, like like because what we learn in these check-ins is that people want, like, they know that their supervisor, their team leader is not going to change their work-family interface, and in fact, if they try to do it, it would be a problem. But they just want to feel acknowledged and listen, and that can go as far. And we did the study and it goes both ways, because we did the study in a very turbulent time, like historic layoffs, the worst organizational crisis. And we are analyzing this data in terms of turnover and layoffs at each clinic. But we heard from the supervisors, from the team leaders, that having the chance to implement the check-ins during this crisis was also a way for them to show their transparency, that they're on their side, but there are so many things, beyond their control. So, yeah, so listening would be at the core of everything. And listening is a behavior, and as a behavior is trainable. And there are so many good trainings. AHRQ has, Team Steps have, for instance, a module on reflective listening, with both verbal and non-verbal ways to demonstrate that you listen. And it's not trivial, but it's teachable, and you can get better at it. I certainly can get better at it.
Sure, listening's like a muscle. You got to keep working at it all the time to keep it strong. Great. Dr. Cooper, you really explained everything and had that pictorial representation of the data showing, how you could look at it, holistically. What if we don't have these sophisticated data systems and processes? Where do we start?
I think when the key things about, particularly where there's a pattern, that sort of that next level up, whatever you've got, if you've got a team of 5, just saying, gosh, Cindy, it seems like I'm talking with you about this more than really anybody on our team. That still provides that meaningful type of comparison. So I always talk about, don't let perfect be the enemy of good in this space, because what we're really after is to give the greatest chance that you will sort of say something, I need to do something different here.
Makes sense. That's great. All right, Dr. Hurtado, how can leaders ensure lower power team members feel safe to speak up, and what behaviors show it's working?
How they feel safe to speak up. I think role modeling is a massive behavior that team leaders can implement every day to build that psychological safety, to get to that space when they can speak up. And following up and following through with what is agreed. I would say those 2 things are paramount, because people notice when you implement the change based on what is discussed. And for the what was the second part of the question? The people without much power within a team?
And what behaviors show it's working?
Oh, what behaviors show it's working? Well, the check-ins is in the not in the you know in the colloquial sense of the word, just checking in with people, getting that feedback. And that's a you know that's a thermometer, but you also want more data systems eventually. I know that Dr. Cooper just mentioned that, yeah, you don't need a sophisticated data system, but at some point there should be a metric that that indicates now, and there's a huge debate on leading and lagging indicators. I much rather prefer leading indicators in terms of behaviors, in terms of more proximal short-term things. In healthcare, as we know, there are so many multi-level, multi-systemic, factors, but leading indicators are more proximal, more behavior-based. So identifying one of those behaviors would be, and consensus would be, team consensus is, okay, how our team want to rate our success? Like, what are the things that when we do, we know that it's working?
I mean,
Great.
I don't, so, I mean, Dr. Donato raises so many important points. And one of the things we find in having everyone in the healthcare workforce feel agency or the sort of the ability to share concerns is that we have to have the humility to know that we're not going to get it right every time. And people won't speak up if they don't have psychological safety and trust. And so, Dr. Donato, your work showed that by having the leaders connect with them, that they were sharing that and making a safe place, that it was at a cup of coffee or a coffee shop, not my coffee, but your coffee, or other things. And that's a really key thing. What we found is that we actually track metrics for numbers of events reported. It's not that we want to get people to start entering safety reports all day, just that we use that as a measure of sort of a report is a tip of the iceberg. We know this to be true. So what we found is that when we address the concerns and the behavior improves, when we go back and report to the teams, we received this number of reports over the last year. We addressed 99% of them, and we're showing improvements. People will begin to respond. One reason why people don't respond, you remember earlier when we talked in our Mentimeter about like how often would people speak up and it was a low number. That's fear. People are afraid they're going to be retaliated against or they're going to be made to feel awkward. You have to have systems in place to also address the rare but important incidences of retaliation, where someone says, I can't believe, Cindy, you went in and introduced one of these stupid safety event reports. I was just giving you feedback about your stupid performance, and so those kinds of things you have to have very robust responses to.
Great. Yeah, thanks for sharing. Okay, I have one last question for Dr. Cooper, and we'll see if anyone in the audience has a question. What should we do for supporting accountability for a clinician and they share a significant life stressor that's impacting their performance? How should we handle that?
And I'm guessing that Dr. Hurtado had this experience in the check-ins as well. And so like when we've got messengers who are out across all of our health systems in our collaborative who share and someone says, I have to tell you that I've had a significant life stressor. Really powerful example of this and really changed our thinking and our framing was early in COVID. Back in the day, those of you who entered workspaces where people checked your temperature and then gave you a sticker that says you've been checked and you're safe for the day. We had 2 straight days, actually 3 straight days. One of our clinicians here at Vanderbilt blew past the screening table without acknowledging the screeners, got in the elevator, and went up to the floor in our hospital. After the 3rd day, the team was like, yeah, this is not right. We're trying to protect each other from COVID. This is really scary. So a report got entered. We sent a messenger to share, and the person burst into tears and said, I'm a really private person. I've not told anybody about this. But my partner is up in our ICU on a ventilator with COVID. And I'm afraid they're going to die, and I don't know what to do. So in that moment, what our messenger did, which was just outstanding, is stop got the person connected to resources to help, got clinical coverage for them so they could navigate this really stressful time. And we never would have known if we hadn't engaged, because they were such a private person, they were never going to tell. So engaging with empathy is so important. And then knowing how to get people connected to the resources within our organizations is such an important skill for us to have as leaders, not just in this setting, but anytime someone shares a significant concern that they may have.
That's great. Yeah, thank you. All right, audience, any questions or comments out there?
Hi, I have a question for Dr. Cooper. My name is Daphne Jarmo, and I am a neonatology fellow at Stanford Medicine. And I think what you were speaking on in regards to the culture of psychological safety and feeling comfortable to bring up concerns is a really great point. And I'm curious about the flip side of that with the at least in Stanford, that a lot of trainees have been having are encouraged to report learner mistreatment. And so for people to provide that feedback over the cup of coffee, I think there's also a little bit of fear of, oh, am I going to be reported for learner mistreatment for singling out this person, especially when some of these concerns can be a little bit more subjective, not necessarily coming out of skipping out on the timeout, but like more interpersonal reactions that can be perceived as very subjective.
No, I think, Daphne, you bring up a really important point. And that's why you have to have a thoughtful process for reviewing to say, you know what, and this is one, I always err towards the side of sharing the concern. So let's say that a fellow in neonatology enters a report about an engagement with attending in the NICU one day on a particularly stressful event. What I do is I don't approach that by saying, this fellow said you did this really rude thing right before the delivery room resuscitation. It really is, I'll start the conversation by saying, hey, tell me how things are going. How's your call night the other night? I know things have been really busy up there. I know you've had several cardiac cases come in, and how's it been going? And they'll often talk, and I'll say, tell me a little bit about what's going on in terms of like interacting with some of the fellows. How's that going for you on your service week? Typically, they'll actually identify for themselves what that is. And then I'll say, yeah, I get that. I can understand that was stressful. Now, any way can you think about from the perspective of the fellow how that interaction might have gone down? And so what I'm using is not to say, this is the facts, this is the case, this is what we're doing, but really a chance to say, here's what I observed. And then the thing that we do, Daphne, to ensure that we protect our learners is really twofold. Number one, if that attending were to say to me, you know what, I'm pretty sure I know who the fellow is, and I'm gonna go apologize, right? So if I sense that there may be retaliation, or even I have any like the slightest concern, I'm gonna say something like, well, I oftentimes people are reporting on behalf of observations they make, and it's not even often the fellow that shares these concerns. But even so, I get what you're saying, but I'm thinking the best way for you to apologize is just not do this again. But because, tell you what, colleague, if you have a conversation with them that any reasonable person would interpret as retaliation, under our professional conduct policy, it really takes it out of our hands. And I think that's something I just want to make sure you're prepared. And we're able to mitigate that retaliation event really carefully, which means then, to the points that have been raised in the chat, you have to have leadership commitment that we will deal with this robustly. So we have taken people offline as teachers of our residents and fellows when we identified a retaliation event that was investigated and found to be true or reasonably true, because we have to protect our learners and create a safe learning space for them.
Great. Well, thank you so much. This was a great dialogue today. We'll keep it going here with our next panelist introduction. So I'm going to pass the baton over to Jen Wright.
Well, hello, everyone. Good afternoon. I'm Jen Wright. I have had the privilege of serving on the Hero Healthcare Summit Planning Committee for a number of years, and it is my pleasure to introduce three distinguished panelists to you this afternoon. Dr. Rain Soriano is the Regional Director of Professional Excellence at Kaiser Permanente, where he leads initiatives in nursing education, informatics, and professional practice. Dr. Soriano integrates caring science and emotional resilience strategies to support nurse well-being and is a dedicated mentor, speaker, and author committed to advancing the nursing profession. And next, we'll hear from Angelica Ortega-Lewis. She is the IT Executive Director for Financial and Administrative Applications at UC Davis Health in Sacramento, California. She excels at assessing new technologies for their practicality, scalability, and ability to support organizational goals. And we also have Carrie Bashirs. She's an accomplished health and wellness leader with more than 27 years of experience advancing workplace well-being and organizational health. She currently serves as a well-being manager with the City and County of San Francisco's health service system, where she leads the citywide well-being initiatives that strengthen employee engagement, resilience, and community. Dr. Soriano is going to get us started. So please put any questions you may have for our panelists in the chat, and we will open it up to interactive conversation once our panelists have completed their presentations. So Dr. Soriano, I'll turn it over to you.
So much, everyone. Just doing a quick sound check. Can everyone hear me okay? It's you know, Murphy's Law whenever it comes to technology, it seems like, and sounds like it's not just me. So that's good. It's a big part of resilience building. So thank you so much, and thank you for having me. Again, Rain Soriano. I lead what we call the Caring Science Academy, and representing over 26,000 nurses in our 21 hospitals in Northern California. And so in 2009, our then CEO, Greg Adams, who's now the CEO over all of Kaiser Permanente, you know, brought what was called the theory of caring science to our organization. And at the time in 2009, he said, this is probably one of the most important things we will bring to the organization moving forward. And, you know, scratching their heads, you know, they were wondering, you know, caring science, what is this theory we're bringing in? And little did we know at the time that he was talking about culture. You know, because as we know, culture eats strategy for breakfast, lunch, and dinner. And when we're talking about leading healthcare, you know, often we hear about VUCA, which comes from the military, right? The volatility, you know, the unpredictability, the complexity, and just the adaptability that we need in order to survive more complex environments. That at the end of the day, it's all about being a human being. And so the theory of caring science, you know, has its origins from Dr. Gene Watson, who developed this theory back in 1958. And it's really a theory with two major tenets. And one is really all about, you know, caring for self. And as we talk about today in healthcare, and it didn't take a pandemic to show us this, but, you know, you can't really put the oxygen mask on others if you yourself are you know, struggling to breathe. And so wellness and self-care is such a key part of this theory of caring. And the second part is really all about the, you know, making sure you have a culture of belonging. You know, one of the great things about Kaiser Permanente as an organization, it celebrates its 80th year this year, but before we were calling it DEI, you know, as an organization, part of the mission and values was already DEI, in that we cared for, we hired, we retained, you know, employees from all walks of life and all journeys, and we cared for all communities, you know, even at a time when that was not the most popular thing to do. And so, you know, living and breathing that mission all the way to today, where, you know, often we hear about things about diversity, inclusion, equity, and all of those values being vilified, you know, in our socio-political climates. You know, for us as an organization, it's part of our values. And so caring science, you know, when we talk about caring science, it's called caring science because of the evidence base around when you're kind to yourself, when you're kind to others, when you just take it back to being a human being. You know, when we wake up, you know, every day, just be a good human being, a kind human being, whether you're at the leadership level, at the care level, and it's really what we call a unitary theory, and that it's not just a nursing theory, but it's a theory for all human beings. And so since 2009, we've invested, in Caring Science as an organization, in that now we're training what we call Caritas coaches, Caritas being the Latin word for love, because again, it's all about loving yourself in order to love others and love your work. And so we are now training up to 100 Caritas coaches to serve our staff and our communities in our 21 medical centers all throughout Northern California. And we're spreading this work to our Southern California and other markets as well, because it's, at the end of the day, it's living out our values. And under the theory, there are these Caritas processes. And so oftentimes people ask, well, how do you know you're living this theory? Well, there are these 10 Caritas processes that we have embedded in our academic practice partnerships. And so through the bachelor's and master's programs at both Samuel Merritt University and the University of San Francisco, we've embedded our theoretical approach to caring for others in their curriculum. And so when we send and invest in, academia for our staff and our employees and leaders, Caring Science is a theory that's also built into academia. So what you learn in school is lived out in practice and vice versa. And I don't know if you can see this, but we're also now doing a book club for our leaders in human-centered leadership in healthcare. Because at the end of the day, again, if you can't be a human being and you talk about, employees and staff who are going through human events, and whether that's grief or stress or burnout, if you can't be there and be there authentically. Authentic presence is such a big part of this work that, as clinicians, as nurses, we can smell BS from miles away. And so, one of the biggest measures for healthcare organizations is care experience. And, although we've tried to bring in models from the industrial industry, the hotel industry, just say the right things at the right time and you'll be fine, we'll check the boxes, doesn't quite work, falls flat, because there's no authenticity there. And I'm proud to say, as a nurse, the reason we've been voted the most ethical and trusted profession year in and year out is because of that presence. At the beginning of life to the end of life, we're there to hold the hands of those we care for 24/7. And it's one of those things that, if you don't have the authentic presence, the building of trust, and that true care for others, it comes through, whether it's your safety, your quality, your care experience outcomes. And so as an organization, we're so proud that our CEOs, our chief nurses, and our executives truly invest in and believe in Caring Science, and all of the micro practices that we have under this program, things like heart math, because we know that, the signals that the heart sends to the brain is 4 times rather than the brain sends to the heart. And so no wonder people emotionally react to things. And so when we can regulate those emotions and stay in a state of equanimity, as we call it, where you're this calm amidst the storm, oftentimes, things go better when it comes to conversations, crucial conversations, being able to do your evaluations, rounding with patients, and really being with patients in an authentic and kind and caring manner. And so it's just been a program that we've invested in, for a long time. And so we're also doing things with equine leadership, where we work with horses. There's a lot of evidence that if you can lead a horse through your feeling in your heart, oftentimes that means that you're heart-centered. And so we've been working with a lot of ranches as well through what we call equine leadership, and where we bring leaders and clinicians to really work with horses through a Caring Science lens, in that if you can lead through your heart, animals like horses who have huge hearts can really feel that. And so, in training heart-centered leadership and heart-focused leadership, those are the types of evidence-based micro practices that we've invested in as an organization. And also, as we know, new nurses or new clinicians within 2 years is probably the most vulnerable, parts when it comes to attrition. And so we've invested a lot of research in what if we apply, heart math, healing circles, and caring science to our new graduate resident programs? How does that affect retention and wellness, for the newest clinicians in our organization? And so we've done studies and have really shown positive results in that our turnover has plummeted when it comes to leaders and new clinicians because of this focus on wellness and really building resilience and caring all throughout those ranks at the front lines as well. And so I think, with Caring Science, again, as an organization, we're so proud and so honored in that it's part of our identity. It's part of our values. As we heard earlier, the alignment with organizational values, the mission and vision of the organization moving forward as we serve, such diverse and underserved communities everywhere. And so just really proud to be here. Didn't really have a lot of slides. I just really wanted to share our work in Caring Science and spreading the love across our organization and to all of humanity. Because again, as an organization, it's all about being a human being and human-centered care, human-centered leadership, as I mentioned, that we're investing in as well. And really just wanted to share our work with Caring Science, my friend. So thank you so much.
Thank you so much, Dr. Soriano. For anybody who's got some questions or comments for Dr. Soriano, please put those in the chat, and we are going to move on to Angelica.
Good morning.
Good morning.
Okay, just wanted to make sure you can see my slides.
Yep.
All righty. Well, so my name is Angelica Lewis. I'm a IT executive director at UC Davis Health. My team support the Epic registration, scheduling, referrals, and the patient billing modules. But that's not all. I also have a team that supports our HR, our payroll, our time and attendance, our general ledger, supply chain, compliance, and legal systems too. So I got a big portfolio. And I want to thank you for the opportunity today to share my story regarding building resilient teams. All right. So today I'd like to describe a typical day in the life of an IT professional. And then I want to share with you my personal story towards building resilience for myself. And then I want to explain some practical strategies from the perspective of an IT healthcare leader. And then I want to wrap up with tying all my key points together. And so, yes. And I will say this, asking for grace, this is not a normal for me. I am doing something brave and vulnerable today by speaking at this conference. So. All right, so let's describe a day in the life of an IT professional. So this slide highlights some of the many challenges I face on a daily basis. Stress is constant in my work. We support systems 24/7. We're like the behind heroes for our healthcare and clinicians. We have to adhere to regulatory and compliance standards. They're non-negotiable often. Our timelines are delayed, and I have to sometimes get 3 to 4 approvals in order to make a system change. We have to constantly ensure that our critical systems remain available for our clinicians and patients. We have to adapt to constant advancements in technology. Everything's about AI nowadays, and they want it faster and sooner. It's very difficult for us to retain top talent. It's very challenging in a competitive market. And overall, it's very difficult to maintain what I like to call work-health balance, right? And it's vital to prevent burnout. And so I think that all of these themes are very similar to what has been shared today. So let me share with you a recent example that occurred last summer. last summer, there was a software company named CrowdStrike. And CrowdStrike is the leading vendor for all security software. So they unfortunately released an update to their system that basically caused worldwide havoc, where everybody started experiencing what they called the blue screen of death. And if you remember on the news, they were showing every airport, planes were grounded, they were canceling flights, and everybody really did think it was a cyber event, but it wasn't. It was a bug in the software code. So for here at Davis Health, the incident started at 11 p.m. We all got text. The senior leadership in IT, we have a certain text that goes out that says, all hands on deck, get on this conference call, critical. We got on the conference call at 11 p.m. At first, we thought we were being, it was a cyber event, and then we quickly uncovered that actually it was a bug in the code. So from 11 p.m. to 6 a.m., we stood up all night together, and we figured out what do we call the remediation plan. And so what occurred is we found a fix, and we had to deploy and design in the middle of the night. How do we get our IT staff deployed to every floor of the hospital, but then also support what we would call our, our clinics, all before 8 o'clock, especially for the clinics. They start at 8, but for our hospital, we started deploying them, and they just went floor by floor, basically going to every workstation that had that blue screen of death and fix their problems. So that's just one example of the many challenges. So that just happened last year. So you can imagine, just to complement the theme, what we faced during COVID-19. So let me get over this. So why was 2020 so challenging for an IT professional? COVID-19, that's where I'm going to start. We being an essential healthcare worker, we had to be front lines, right? I know we're in IT, but we were also required to be on site and supporting any workstation or system outages. We had to rapidly, without, how would I say, a previous playbook, transition to a complete remote workforce, and we had to adopt new technologies. And it was sometimes quite stressful for our end users who didn't know which cables at home to connect. They didn't understand what a VPN was. And we had to be very patient on the phone with them. And then, overall, we had widespread social unrest and fears that were just draining. So what happened for me, that this all started on March 13th, and I remember it very vividly, because I was sitting in a conference room. It was our typical IT leadership meeting. And one by one, around 2 o'clock, I think I remember, it was our afternoon meeting, everybody's phones started to buzz, people who had their phones on their tables. And everybody was picking them up. And, either it was their child texting them, come pick me up, my school is shutting down, or a spouse or partner saying, I'm being sent home from work, I don't know what's going on. And from that March forward, I worked nonstop every day until July 2020. So let me tell you what I did in July. So what did I do in July of 2020? I saw an email from our learning and development team that there was an opening in a course called Reigniting the Spirit of Caring. And I had seen the course advertised before. I was very intrigued by the description. And I just kept saying, oh yeah, one day I'm going to have 3 days to go to this class. But that day in July, I pushed the registration button. And just like that, I felt hope. Like I just knew something was going to be different. So I was very grateful that my manager was supportive, and she told me, go, don't take your laptop. She's like, do not take your laptop. Have your phone. I'll text you if something comes up. So on that first day of class, I walked in depleted, exhausted, And honestly, just looking forward to just disconnecting for 3 days. And I told myself, I'm going to participate, I'm going to be present, and I'm just going to take it all in. And I got to tell you, I really did participate. I embraced every lesson. I was brave. I was vulnerable. I cried. I shared so much with perfect strangers. I just felt this sense of support when I was in that class. And I had the most amazing 3 days, and I had the most amazing facilitator, Teresa Pack. I highly recommend you take a picture of those two contacts, Jessica and Teresa. Kind of, encouraged me to show up today. So they really feel that I have a story to share with you. And then this class, it changed me. It changed me at a professional level, at a personal level. I just took it all in. I just embraced it all. And then I went to the next class, which was See Me as a Person. And then the third class in this series is Leading an Empowered Organization. And that one was mine. That was like, the kids say that was my jam. That was my jam. So I am currently learning or being trained to be a facilitator, a Leo, because I was so bought in that we need to lead by our heart, especially in a healthcare organization, but especially in IT. And so I'm determined to be that different leader. Okay. So let me tell you more about Leo. So Leading an Empowered Organization is a 3-day workshop. It was designed to equip leaders with the essential skills to empower their teams. The workshop focuses on critical areas such as leading change, building capacity, nurturing strong relationships, and defining clear expectations for your staff. One key concept is understanding the distinction between responsibility, accountability, and authority. And then the facilitators use these exercises and videos where it really helps the participants practice some of those principles while in the class. So therefore, when we go back to our normal jobs, we've already kind of worked out some of those kinks, and we give each other feedback in the classes. So I just love Leo, and I'm, like I said, I'm very excited in my journey to become a Leo facilitator. My biggest takeaway from Leo, and I think it was said before, was authority. It's the RAA principle: authority, responsibility, and accountability. I'm constantly asking myself, one, am I accountable for this work? Am I responsible for this work? Or I'll say, do I have the authority to make the decisions regarding this work? During meetings, my team will tell you that Angie holds up her hands with the little diamond, question, and I'll ask them, so who can help us with this task, guys? Or I'll say, who knows more about this topic than we do? And then I'll say, is there a learning opportunity for someone else to perform this task? And so they know that I incorporate these concepts in my day-to-day with them. So I really enjoyed the Leo class, and I highly recommend it. All right, so let me share some practical strategies that I use. So I think, like other speakers today, focus on people, focus on your relationships. I can double down on that and say that it is super important. As a leader, you have to be an active listener. You have to show empathy. You need to provide recognition and gratitude. I encourage open communication, and I show them a lot of support, not only in my words, but in my actions and in my tools. Like, what do you need from me? How can I support you with this? And then building trust is being a fair, reliable, and consistent leader. You want to make sure that everything is consistent and fair with your staff. And then ultimately, you want to foster collaboration. I personally prioritize my relationships and my staff by committing 30% of my calendar to them. That's significant. So at least 2.5 hours a day, I'm spending time with a staff member, I'm spending time with a peer or a stakeholder or some other type of partner, spending that time with them. I'm very, I have this kind of script in my head with my one-on-ones where I ask them first, how are you? And then they'll say, I'm doing okay. And I'm like, okay, how are things at home? And they'll share with me. And then I'll ask, because I have directors and managers that report to me, I say, how's the staff? How are they doing? Is everybody doing okay? Is there anything I need to know? And then, I'll ask them about their customers or their stakeholders. And then I'll eventually get to work, right? And by that time, we've kind of built this, I call it this tone. And when we get to work, I kind of say, hey, is there any barrier you need me to remove for you? Or how do I support you? And, sometimes, you have to get things out of them. So I'll ask questions like, so give me a high and a low of your day. Like, what's going on? What's stealing your energy? What can we do? And that usually gets them going. And I use a very similar approach and agenda with my stakeholders. I kind of open up with, like, how are you? And one technique I did recently was, well, actually, after I took the class, I used to have, the 1 hour every 2 weeks one-on-ones. So I changed that and I asked them, what do you need from me and how often? I'm going to let you dictate our one-on-ones. Do you want them weekly for an hour or 30 minutes? Or do you want to meet bi-weekly? So I kind of empower them to make that decision and move forward. They love that. And sometimes if they're working on a critical project, they might say, Angie, I need more time with you. And I'm like, let's do it. Or they'll say, you know what, things are really good. I'm going to give you back some time in your calendar. So I absolutely love that. Communication is, to me, the second biggest thing. Be very intentional in your communication and the information you share. That's super important, because what will happen is staff will make up a story in their mind if they feel that you're not saying something or you feel you're not sharing. I'm intentional where I say, these are the public information I can share, but there's content I can't share. And when it's available or I have permission to, I will share that. So just being very truthful with them. I try to provide as much detail as possible, give them the full backstory, the intent of my communication. I give them good and bad news. I usually start with bad and then I give them the good. I'm very transparent, almost too transparent. I'm too truthful. And I like to give them honest feedback and set realistic objectives. And most importantly, I do create a safe space, right? I always say, like, okay, this is our team culture. We are safe. You can share whatever you want to share. My staff will often hear that I'll say, hey guys, 15 ideas are better than one. I have a leadership team of 15. Or my other favorite line is STP, same 10 people. That means the same 10 people get assigned the hardest work, hardest projects and hardest item of tasks at the hospital. And when we do get these really hard tasks and they're always saying, oh, it's so unfair. Why is our team always getting these really complex technology projects? I always tell them, listen, there are no adults in another room that are going to come in here and give us a solution. We are the adults and we do hard things. What do you need from me? How can I support you? How can I give you air cover? Let's do this, because, I always say we have to ask for the tools that we need to do these really hard things. So what do we need to do? So they always think that's funny. They have these, they always say that. Angie and her sayings, which I do have quite a bit of sayings. The next strategy that I use is I try to foster leadership development by providing clear, constructive feedback. Leo has a term called clarity is kindness, and I totally have adopted that in just my basic communication and leadership skills. I encourage self-reflection. I'm like, did you do everything you needed to do? Was there anything more you could have done? I encourage realistic. I give them support, and I don't try to problem solve. What I ask is, how can I support you with this? Is there something actionable that you're asking of me? And it really helps them kind of frame, their venting or their problem, because they're like, no, you know what, Angie, I just thank you for just letting me vent it all out. Thank you for just letting me clear my head. Thank you for asking me probing questions. I'm like, okay, I'm here for you. Like, if you have an actionable thing for me to do, I will do that. One of the things that I really recently started doing, and they know that they find it funny, but I often encourage the staff when they demonstrate a core competency. I kind of stop them in the hallway. I'm like, hey, remember to put that in your performance eval, because I'm going to forget this great thing you did. So one recent example was we recently had a system outage, and we didn't have the system for 14 hours. And it was actually our RI system where you report incidents. So that's kind of a big deal. We had a lot of tickets. We told everybody just document everything on paper. So I was pretty upset with it, but I said, you know what? I'm going to have Brian handle it. So I said, hey, Brian, we need to open a grievance claim against RL. And he's like, I've never done that before. And I said, it's okay. I'm going to walk you through it. We're going to practice. And I said, you're going to channel your inner Angie. So he called the vendor, and he had his root cause analysis document. He had his contract, with the little blurb about, compensation when the system's down. And he hosted the meeting, and the vendor took full responsibility. And he sent me a chat. He's like, they're going to send us money. They're going to send us a check, he said. And I said, oh my God, that's awesome. So, I say, hey, congratulations, Brian. I said, I'm so glad that, you did that. Please remember to put it on your performance eval, because I want to remember this great new thing you did under vendor management. So I also like to encourage my leaders to practice tasks that I do. One of the examples that I do is, our department meetings. As the department leader, I normally host the meetings, but I started introducing something new. And I said, hey, each team leader and team will have to present a 15-minute presentation and outline all the great things that you're doing and share it with the rest of the department. At first, they were super apprehensive, like, I don't want to put together a presentation. If you IT professionals do not like public speaking, how I mentioned earlier, this is a real stretch for me, but I'm here. And so they got creative, right? So one team opened the department meeting sharing music videos from the 1990s, and that was kind of fun. Another team, they started doing the interactive polling and asking fun questions and asking staff to share pictures, like, hey, share a summer vacation picture or share a family graduation pictures. And the staff in the department really got into it. So now they're so creative that they have team names. And so I have the Dream Team, the Susanna Awesome Team, the GOAT Team, the Silent Ninjas, and the Rule Followers. So the Rule Followers, that's the team that supports our compliance and legal department and systems. So I thought their team name was funny. So whenever, like I said before, when I try to give someone a stretch goal or a new assignment, I often am very intentional in saying, I'm teaching you this skill so that one day you will be able to take my job and I'll be able to retire sooner. And I do believe my team and my staff appreciate my investment in their learning professional development. Focusing on collaboration is very critical for an organizational success. I definitely emphasize teamwork. I share open and honest information timely, right? You got to be timely. You can't share something 3 days later because it's stale news. I am very inclusive. I always ask them, give me your input. I have this idea, but I really want you guys to enrich it, poke holes into it. We have sharing time at my leader meetings where we just kind of go round robin. I'm like, Anybody learn anything new today? Did anybody, want to share some kind of AI prompt tool that we're all using? So it's kind of like shared time. I like to align our individual and team goals ultimately to the organization. In IT, I often have to remind my staff, okay, I know we do the system work, but without the system work and without the data, our clinicians can't make clinical decisions on behalf of the patient. Or without us, uploading the test results for a patient, they won't know like what's going on with their health. So I'm constantly reminding them that we do matter in the path for care. And then I definitely foster a culture of creative problem solving. I try to show empathy, and I think that because I show it and I speak it, my staff are adopting the vocabulary and the actions. I see it because we often have critical projects, right? That are and everybody has their projects. And sometimes I'll just come to a meeting. I'm like, all right, guys, which project can't fail? And they'll name Project X. I'm like, then you know what? All hands on deck. We're going to go help Sandra make Project X successful. And they just do it. It's just like this natural thing that they do. I also kind of encourage continuous improvement. And just like the previous speakers have said, we also had our first town, well, I guess in IT, it was first time in 20 years, because I've now been here 15, where we had layoffs in IT, right? And it really shook the staff. And so I'm constantly, reminding them we got to do more with less. We got to be strategic, we got to work smarter, not harder. We need to become better problem solvers. We got to be critical thinkers. We got to be adaptable and agile. And, of anything, I say be curious, ask questions, lean in, don't make assumptions, right? And especially now with AI and bots and rapid technology advancements, I said let's look for automation where we can, so we can offload some of our repeatable tasks, right? It's like if we're doing this constant, then I would prefer that we automate that process and not and use the your big beautiful brains for something else. I personally love to solve problems. It could be my engineering background. I take every problem like a math word problem. What variables do I know? What do I don't know? What can I derive? And I literally, when they're telling me about a problem, I do use my hands a lot. And I'm like, all right, let's go to the whiteboard. Let's do this. What do I know? What do I don't know? I use this concept with them quite often. I like to ask them a lot of questions. I don't want to give them the answer. I want to teach them how to problem solve. So I'm very intentional in holding back like the answer. And I'll ask questions like, where would we be able to find that information? Who could be a source of, reference for us? What tools can we use? So that's where I go with let's work smarter, not harder. And, God gave us these big, beautiful brains. Let's use them. And so in conclusion, I specifically chose this image because to me, team means together, everyone achieves more. It's kind of my team motto. Focus on your people to achieve more. Focus on your communication to achieve more. Develop more leaders. That's like my big one right now. Collaborate to achieve more. And finally, encourage continuous improvement to achieve more. The relationship-based caring program at UC Davis taught me to lead from the heart and lead by example, to be a brave leader who brings warmth and support to a stressed IT division, to use words of gratitude and empathy, and to just be a better person and a better leader every day. I'm often asked, how are these strategies working for you, Angie? And I'll just say, I'm constantly stopped in the hallway to ask if I have openings in my department. And, I also feel like a sense of compliment when my staff uses the words, I'm channeling my inner Angie. I'm being grateful. I'm displaying empathy, and they use the vocabulary that I have shared with them. And so I always tell them I'm very intentional. I said, that just warms my heart when you use words like that, especially in our division where it's not a touchy feeling division, but I'm going to change that culture one day at a time. And so I thank you all for this opportunity to share my story of resilience.
Well, thank you so much, Angie, for sharing your bravery and your story with us. You asked us for grace at the beginning. You certainly had it, but you did not need it. You did a great job. So with that, I think we're going to move over into a presentation from Carrie.
All right. Thank you for having me here today. I'm really excited. I'm going to take a little bit of your time to talk through the well-being landscape within the city and county of San Francisco, talk a little bit about our strategy from one of the departments that was within CCSF, in addition to the well-being program, some of the data that we've seen, talk about challenges. There's been a lot of challenges throughout our evolution of well-being for the city, where we're going, what we've got planned. What I like to say, if I had my perfect crystal ball of what types of things I think, we could implement within the city, and, some lessons learned. So a little bit about this city. I wanted to kind of just set the scene. So for those of you who may not know, can kind of get the full picture. So there are 4 employer groups within the city and county of San Francisco. So first and foremost is the city and county of San Francisco. There is the Community College District, the Unified School District, and the City Courts. So when you look at those 4 employers, they make up about 55 city departments. City and County of San Francisco is the largest. And then if you look at the next 3, basically, then there's about 52 departments within City and County of San Francisco. And then the other 3 are the other 3 employers that I mentioned. There's approximately 45,000 employees, so a very large employer when you think about city and county. And then there's multiple work locations. I think most people would think, oh, well, you are in the city, so you must work in the city. Yes, a majority of the locations where people work are in the city. However, we have locations in Millbrae. For those of you who may not know, but it's very close to the San Francisco airport, Sunol, and then Moccasin. If you're not familiar with Moccasin, Hetch Hetchy is out there, which is where all of the water that comes into San Francisco is really funneled, and Moccasin is actually not too far from Yosemite. So for those that are more familiar, distance-wise from San Francisco, it's probably at a minimum 3.5 hours away. So again, a very unique environment that we have out there. One of the things I like to quote, so my executive director, a retired executive director that I worked under for several years, retired last March of this year. I'll always like to quote what she says because it's very real that when you think about the city and you think about the departments, it's like when you've seen one city department, you've seen one city department. And I think my goal today is to really share that in the challenges we've had are definitely related to the silos that we see within the city departments, because everyone does a lot of unique work. And sometimes there is some overlapping, but very little does that happen. So I really look at the work that we do out of my department, really uniting and bringing the departments together through some of the systems that we have built in place through our well-being program. All right, so shifting gears, I actually sit in the Department of Health Service System. So we are one of the 52 City and County of San Francisco departments. We basically have about 55 employees within our department, give or take a few. We also have 7 different divisions. So within those divisions, one of them is well-being. We also have contracts. We have our data and analytics team, finance, communications, and then our member services, which is our member facing, more of a call center that does a lot of the benefit side of our work. So kind of shifting into what we do, we administer benefits for all active employees and retirees for the city. Collectively, that makes up about 120,000 lives because it does include spouses, domestic partners, and dependents as well. A little bit about my team. We are small and mighty. I feel like that's kind of the consensus these days with, I know, a lot of impact to budgets and downsizing of organizations, but we have there's 5 of us. So it consists of myself as the well-being manager. I have 2 well-being program coordinators who do a lot of work specifically to support our departments. And then collectively as a whole, we do support our retiree population. And then I have also oversee an EAP program. So our EAP program is a little complex in that we have 2 senior EAP clinicians. And then back when the pandemic hit, we decided that we didn't have enough folks on our EAP team to support what we anticipated would be an influx of services to our employee assistance program. So we actually have an external vendor as well that helps to support our team. And then I can talk a little bit more about the nuances of that as I kind of go into more of the program that we've done to support mental health. In regards to our mission, our department's mission is really to ensure equitable, sustainable, and quality benefits to enhance the well-being of our members and their families throughout their life cycle. So I have also included a little bit about our vision and values, but I won't necessarily go into that today. From a department standpoint, we have a strategic plan that actually went from 2023 to 2025. We just had a full switchover of our executive leadership in April of this year. So that also includes our executive director, our COAO, which was basically your equivalent to a COO, just a different title that we have. And then we actually have a open position right now for our CFO as well. So all 3 of those individuals will be new or are new as of earlier this year, which a lot of times in that case does kind of shift a little bit in the direction that we will be looking to tackle well-being. However, because of our strategic plan goals ending this year, we are going to be extending it into 2026, which allows us more time to develop our next 3-year strategic plan period with our new executive suite on board. But in front of you, I have the 5 strategic plan goals that our department is focused on. I actually occupy strategic plan number 4, which is supporting the mental health and well-being of our members by reducing stigma and addressing our mental health in the partnership with our key stakeholders. And our key stakeholders really involve a lot of different people. There are health plan partners. There are partners in the space of EAP. Credible Mind is actually one of our partners. And then we look at our key stakeholders as the departments and those that we serve in our what we call our members or our community. Additionally, to talk a little bit about well-being, I actually still consider our program to be fairly new. We like to think in the city that we're very progressive, and yes, I think we are in some ways, but the well-being program didn't actually get established until 2014. So we're only 11 years new, if you want to call it that. A lot of folks say, well, that sounds like you've been around a while. But to be honest, we really haven't. We still meet people today in the city that says, I did not even know that you existed. And that's what I mean about silos. It's very, very interesting in the city is that departments are very siloed. And so we have some main goals that we're looking at in regards to well-being. Obviously, we want to improve the quality of life for our city employees, our retirees, and their families. We want to improve the health outcomes, by looking and providing, preventive measures, preventive screenings. That can come through us in the well-being division, or it could also come from our health plan providers. We want to look at managing our conditions. Ultimately, I think a lot of our goal in well-being is to reduce costs for healthcare, and then also looking at how we can partner with our workers' comp, and looking at disability so that we can, again, control some of those costs. One of the things I wanted to call out, because I think it's important, that I am in a department that is not HR. So that is somewhat unique, I think, in some well-being or even benefits administrative type organizations, is that we're not DHR. So HR serves employees, but because we serve our retirees and their families, we are completely separate. So I would say that one of the big challenges that we have is that a lot of policies, or I should say all policies, are driven by HR. Workers' comp driven by HR. So there's a lot of systems that they have in place that we do interject with and utilize and support and encourage our departments to implement, but we don't drive those. And so that is something that we definitely have challenges in how we work in a city system. In regards to our well-being goals, basically we look at how we attack our goals with, how do we structure the different components. And we look at leadership and infrastructure, we look at motivation, we look at programs and reporting. So when you're looking at leadership and infrastructure, it's really about, how do we educate and inspire our leaders? We as a group also manage a well-being key player network. I'll go into a little bit about that key player network because it is vital for us. Being that I mentioned there are silos in the city, it is very important for us to utilize those that work in these departments that know the culture, that speak the language, to help us spread that message and to bring these offerings to their worksite location. Our goal is also to align the existing city resources. There are a lot of things that happen in the city that other departments are doing that we can tap into. For example, Rec and Park. They offer group exercise classes. If we want to be able to offer those, how do we go about leveraging that department to be able to provide these services? Or in the example of DHR, they have a workforce development division that does a lot of training. So how do we leverage their training and inform people about it so that our folks can utilize those services? Also policy, I mentioned a little bit about policy. So a lot of it is like, how do we look at the policies within the city? How do we align those policies and really encourage departments to implement those with a lens of well-being? And how do those policies help to support the well-being of our workforce? Motivation, right? It's just, how do you remove barriers? So bringing it to the work site. How do you reward people? Giving them little fun tchotchkes if we can. Celebrate and recognizing our departments. And celebrate and recognizing those who take time to engage in self-care and do this at work. And then we have the programmatic side. So again, reducing those barriers about bringing it to work, designing programs so that people can engage. How do we leverage our key players through education and tools and resources so they can bring those back to the workplace, and then promoting and supporting all of our city departments. This is actually done through what we call a well-being strategic plan. I'll dive into that a little bit as we go into the data piece. And then, of course, I think like all of us, reporting is very, very important in the work that we do. We look at it at a lot of different levels. We have obviously participation, satisfaction. We've done a well-being survey. We do it about every 2 years. We did skip this year, so the last one we did was 2023. And then we have a lot of different programs that we offer that we collect and report out for data. So a little bit about, where we started to where we've kind of come. I would say we were very traditional. We focused on healthy eating, physical activity, stress management. We've always had our EAP program there. Mental health has always, been there, but it hasn't really been elevated. And I would say, as similarly some other folks have talked about the pandemic kind of being that snap, it was similar for us where we said, we're going to make this commitment to mental health and we're going to take a shift and look at everything starts there. If you're not feeling good about yourself, if your mental health isn't in the right place, wherever you feel like that is on that spectrum for your mental health, then people aren't going to be able to eat well. They're not going to be able to be physically active. They, really want to manage that. So we started to look at how do we address specific topics around mental health. We implemented a toolkit for departments related to recognition and appreciation. In our well-being survey, we found that sleep was really important of an interest topic. So the last couple of years, we've done a sleep campaign for our employees. And so I wanted to kind of shift really quickly in regards to data. I know there's a lot of data on the page, so I'll just speak about it. So as we shifted to focus on mental health, and part of our strategic plan goal is to implement a mental health awareness campaign every year during the month of May, which most of you probably know is Mental Health Awareness Month. In our strategic plan goal, it is to increase participation and engagement by 5% compared to the prior year. Engagement for us is basically looking at a couple of different things that we offer. One is assessments, which is through our Credible Mind platform. It looks at the number of cases that we get through EAP. So for those who may not know, cases is basically when I call, I now get services to seek EAP services. I've been given a clinician. I can now seek those services. We call that a case. We also look at workshops. So we offer things like mental health first aid, stress first aid, psychological first aid. And then we offer trainings. So trainings are more like your 1 hour. It could be anything on self-care to meditation. So collectively, we look at engagement and participation. So from 2023 to 2024, we not only met that 5% increase goal, but we exceeded it by an additional 10.9%. This year's a little different. So we did see some differences in the shift in our data this year. But we've really been pushing a lot of EAP. EAP for us, particularly our internal EAP, focuses specifically on not just individual services, but organizational services, consultation, navigation. We really look at them as kind of that first point of contact for folks who are trying to navigate through different systems. And that could even be well-being. It could be through their health plan as well. We see about 9% of our population actually call into EAP, but I would say more traditional of what you see with most EAPs, we get about 3% utilization. So that's 3% it's about 3% of the 9 who are calling are actually the right fit for those services, but we are getting people who are navigating into other systems and programs that we offer throughout the city. The other thing too, I really wanted to highlight was to talk a little bit about department engagement. So we manage, as I mentioned, a key player network. Our key players make up 3 different critical folks. One is a manager that is within a department. The second is a champion. So the manager we call a lead. The champion can be anyone of all different levels. And then the third is a coordinator, and that's one of my 2 coordinators that sit within my department. And collectively, our goal is to provide consultative services to help our departments to develop a strategic plan. There is no well-being policy within the city. So we highly, highly, highly encourage our departments to develop a strategic plan. We have about 52% engagement with that, which is great for us because, again, without a policy, and I hate to put a policy out there, but sometimes policy is what drives your participation. And in our case, we've been able to have success without a policy. And our departments are rewarded for that. So we have every 2 years an award ceremony where we get about 200 folks, about 100, I would say more like 150 to 200 of our city departments, our champions, our leads, our directors attend. And it's one of our opportunities to really highlight and showcase our departments and the work that we do and that they do and that we do with them in that, because it is really a partnership that we have. So a little bit about changes. The changes are really being driven by executive leadership. Mental health isn't going anywhere. One of the things I'll call out with our Mental Health Awareness Month campaign that we did this year, we did have a full focus on civility in the workplace. There is an actual policy within the city that highlights and aligns a lot with that. It's called equitable, fair, and respect in the workplace policy. In addition to that, our DHR partners have a respect in the workplace campaign that they've done along the lines with that. So our highlight was really around that. I would say, you know, it's for us, it's a work in progress in the sense of the work that we do from well-being and leveraging our key stakeholders. Where our leadership wants to move the needle is really driving a lot of those healthcare cost claims. You know, so to be frank, doesn't mean things that are going away. We're going to get rid of what we're doing. It's really more about re-elevating some of the things that we used to put into practice a number of years ago. And it's really focusing on, you know, knowing your numbers, being physically active, encourage people to eat healthy, driving them to their health plan benefits, because we have some pretty rich benefits in the city. And then I have a goal really for targeted programming. You know, we've always looked at a lot of pilots in the city that we've done that sometimes have actually launched into larger efforts for us. But in this case, targeting our departments, more specifically around mental health, civility in the workplace, healthy eating. So kind of that whole encompassing focus. And then really where I kind of say it's like my magic wand, crystal ball, things that I think I would love to see in the city. I've been saying this for the last 11 years that I've been with the city. So I'm very hopeful and optimistic that at some point these things will either be brought back or we'll focus on these in the future. But one is an advisory committee. Because we are so siloed, it would be, I could really see a great benefit of leveraging our leaders across many departments, bringing committees together to really help make decisions and what we do for the sake of well-being for our membership. Getting unions involved. I know there are some municipalities that have had a lot of success in bringing in the unions, having them be the voice, creating that policy. So policy is obviously one of those aspirational ideas that I'd love to have for our city. I also would love to see each department, because each department has their own strategic plan, their own goals, vision, mission, building those well-being elements into those strategic plans. I think that also includes things like management training. A lot of what you've been hearing from these other panelists are really about that training that's specific to help create a culture of caring that then can support the employees so that they want to show up for work every day. They're invested in the work that they do, and they really want to be a part of the teams that they work on. And then I've seen some success where we've had a well-being integrated into the performance reviews, because that also really ties in accountability. And I think that's a big thing because of the work that we do out of my department. Is the only real accountability that we have is directly tied to those strategic plan goals that each department chooses to work on and to implement. And then just to wrap up, I think, you know, one of the things that, you know, we've learned that hopefully I've kind of messaged throughout today is, you know, we have such a diverse population that there's really not one size fits all. And that's where my coordinators really come into play to take some of the information or the toolkits or the programs that we've come together and we've put out to our departments and say, how do we customize that for you? How do we bring this to you? You know, so that it speaks to your folks, whether it looks like them, speaks like them, but it talks to them and resonates with them. I think, you know, our lesson learned is building relationships. So whether that's as a leadership level or in the work that we do in well-being, is building relationships is critical. And I think that has really helped us to be successful in managing that 200 network or so of our key players. And then I think one of the things that I've had to do very quickly is pivot quickly, right? The pandemic made us pivot. I have a new executive leadership, so that's saying, okay, let's pivot. But also looking at, you know, the data and what data is going to help drive decisions for the future. And then I would say, again, just reiterating for us, what we've seen has been really successful is piloting. Where can you target? Where can you pilot? How do you iterate? And then just continue that message throughout. So I just want to thank you for your time. On the screen is my information. Please feel free to take it down, and I would welcome anyone to reach out to contact me.
Thank you so much, Carrie, and thank you all for sharing your perspectives on resilient teams. In order for us to stay relatively close to our agenda timeline, I'd like to ask just one follow-up question to close out the session. And I don't see a specific question for our panel in the chat, so I'll pull from one of my own. First of all, Dr. Soriano, thanks for sharing the Caring Science Academy at Kaiser Permanente link with us in the chat. So I would invite all of you to make note of that resource if you haven't already done so. So Dr. Soriano, how can organizations intentionally integrate caring science or some kind of similar human-centered framework into their wellness strategies that strengthen both staff resilience and patient outcomes?
Thank you so much, Jen. It's a great question. I think our panelists alluded to, many of those key success factors, and it starts with leaders. I think, in 21 hospitals that we serve, you could tell where the culture is caring by just the way people, look at each other, know each other's names. I think, when Angelica mentioned, as you're talking to staff, their pets, their family members, there's a relationship, and we talk about our organizations being relationship based or relationship driven, and without that buildup of trust at all levels, starting at the leadership level, it's really hard to, have highly reliable organizations or cultures of safety, because when you're scared to speak up, or when you feel like, if you speak up about the wrong things and retaliation occurs, don't be surprised when there's, your scores and the outcomes, show the system that it's built upon, right? And so I think for us, in order to sustain this, it's having, and I'm glad that the KPI issue will be addressed in November. So thanks, Karen, for sharing that in the chat. Because unless you can tie your metrics and your measures and your impact and your outcomes to the investment in wellness and caring, good luck, investing and sustaining these programs. Because, when we talk about, again, care experience, quality, safety, it has to have a foundation of caring. Because if you don't care for the people you're serving, much less the communities, the patients, then again, the proof is in the pudding, and to do it in an authentic way. And to what, a mentor of mine always said is, you have to inspect what you expect. And so, in order to do that, the numbers have to show that as I continue to invest in wellness and caring, it leads to better outcomes, better care experience, and just overall retention and workforce wellness, at the end of the day. So I think those are the things that we have to continue to connect the dots with, Jen, in order to sustain these programs starting at the leadership level.
Thank you so much for that. That was an incredible recap of the conversation during this session, and something you just said about aligning those metrics with what our priorities are. A colleague of mine years ago used to say, measure what you treasure, and you treasure what you measure. And I think that really is how we move forward in a data-driven way. So
we
again,
also
go,
say,
please.
Jen, one more thing. We always say
Yeah.
we are human beings and not human doings.
Yes.
And so, gets back to being a human being. So thanks again so much for having us.
Oh, yes, thank you. I'd really like to express our gratitude to all of our panelists for sharing their expertise and examples of building resilient teams through their respective lenses. Now we're going to move into organizational compassion, and I'm going to turn it over to Dana Miller.
Thank you so much, Jen. And I am really excited to present our final speaker for today. I am a workforce health consultant with Kaiser Permanente and a member of the Healthcare Summit Planning Committee this year. And you're in for a treat. Dr. Sarah Agha-Mohammadi practices pediatric critical care medicine at UC Davis Health in Sacramento, California. She has been passionate about clinical health and well-being since her residency training and was appointed Chief Wellness Officer at UC Davis in July of 2022. As Chief Wellness Officer, Dr. Agamahadi. I was practicing saying your name. Dr. Sarah leads and directs wellness and well-being programs and initiatives for the medical staff and the health system. She collaborates with health system leaders to identify, develop, operationalize, and implement strategies and initiatives that target improvement in culture of wellness, the efficiency of practice, and personal resilience. Outside of her professional life, she is a performer, instructor, and board chairperson of the Sacramento Comedy Spot, a nonprofit comedy theater and Northern California's largest comedy school. Welcome, Dr. Aghamahadi.
Thank you so much for that introduction. And you said my name perfectly. So kudos to you for that. Thank you all for having me. I just want to make sure you're seeing the presentation view, not the presenter view. Okay, great. Yeah, I actually gave this talk at a health management forum at UC Davis Health. And I want to give you a little bit of context behind it because it really speaks to, I think, what felt like the climate a year and a half ago. And I'm realizing it's always kind of this climate of how do we not only treat each other with compassion, but then as an organization, how do we really espouse what we say our values are? Because I think people, especially within an organization, it's not so much, we're not really paying attention to like what strategic marks you're trying to hit as an organization. When I'm on the front line and I'm, working clinically, what actually I pay attention to, what I'm feeling is that sense of, does this organization, do the leaders actually walk the walk and talk the talk? And actually, are there strategic plans in line with what we say we care about? So that's where organizational compassion kind of comes in. So before we get started with that, I do want to give a moment of pause. I feel like it feels like this every week when I say like, wow, what a week. And this feels like every single week. And the last one, notwithstanding, that it's just a very intense time, whether you think about politics, whether you're thinking about just current events, just everything going on, it's a lot. So I just want to start by acknowledging that this is a really tense and difficult time for organizations, for us as individuals, for our country in a lot of different ways. And it's affecting each of us in a very unique way that really has to do with our identity, our intersectionality within different identities, as well as, sometimes you're just looking around and you're thinking, I'm just supposed to go about my silly life when all of this stuff is happening around us. And so I just want to acknowledge and validate that feeling because I think that is the moment to turn inward so that we can turn outward. And along those lines, what I'd like to reflect on, as opposed to having any objectives, is really just some core reflections of how do we reflect our values? What can we do as leaders to truly see and hear people? That's come up in a number of our previous sessions. And what does organizational compassion mean, and how do we nurture it? And then finally, the goal is how do we foster a sense of belonging? And I think that is the difference between saying you just work at a place as opposed to saying that you are a member of that organization, right? It's like that sense of school spirit. And I think that is the thing when we think about retention is, the sense of pride, the sense of I'm a part of something bigger. I'm not just clocking in and clocking out. Particularly for those of us who are working in, I think about that, working in an academic institution, there's so much more than just the clinical work that we're doing, which is so important, but there's so many different facets to the work that we do, so many things that pull us in opposite directions, teaching, research, whatever it is, that are part of this bigger mission that we have and greater purpose for why we show up to this particular place. And I think that when you create a sense of belonging for people, that is the X factor. That is the thing that you can't put your finger on of why you stay somewhere as well. So let's just start with kind of defining what a well culture looks and feels like. Well, there's a leadership commitment to wellness and an infrastructure to support it. So that's often, positions like mine, well-being directors, chief wellness officers, with staff, like we are a small but mighty group of people that are working to specifically within clinician health and well-being. But really, I try to be that voice as well as that person that people can turn to from all areas of the institution for advice and for counsel, and whether it's as a leader, a supervisor or manager, or as an employee. It's important to measure wellness. That comes with a lot of strings attached, because a lot of times people also realize, like, I fully appreciate that surveys are important and also very annoying. There was one week where I think I did like 3 surveys, and one of them I did twice because I just couldn't remember if I had done it. And recognizing that when you're asking people for information, when you're asking them to share something, especially when it's related to like feelings like burnout and, their sense of engagement with where they work, you're touching on a very personal and sensitive part of them. And it's gonna unearth maybe some feelings. And so if you are soliciting that information from people and you're not showing that you're doing something with it, that you're saying, hey, I'm asking this question and I'm going to respect this as a two-way conversation. Here's what we did. We heard you and here's what we're doing. Then you're going to lose buy-in from people. They had to go to a certain place to be able to really reflect of like, man, am I actually happy here? Would I recommend this institution to, a friend, a colleague, a family member? And if not, why? And what does that mean about me if I'm choosing to stay here? So these are really, we don't really think about it when we're asking those questions, but it stirs up a lot of kind of tertiary thoughts for people that that really make them start to question. And then if you don't do anything with that information, they kind of feel cheated, that I shared something with you and you did nothing with it. So I'm very careful and cautious about how we measure wellness, but more importantly, am I being intentional about that information and respecting the information that was shared with me? Finally, or in addition, in providing recognition and appreciation. And along those lines, very closely related to it is, are we working in an environment that is being fair and inclusive? I talk a lot about community care as opposed to self-care. I think self-care is very important. And it is something that only you can provide for yourself. But if you are feeling burnt out, it is not from a lack of self-care. Oftentimes you're working in an environment where you aren't being given the time, the space, the ability to be able to provide for yourself. And so what community care is a sense of that people thrive in environments where their needs are anticipated and valued, and that recognizing within a group dynamic, people within that space have different amounts of power and privilege that other people may not have. And that by utilizing that power and privilege, by recognizing it in yourself and being able to lift up the greater whole, you are now allowing for people who don't have access to that to be able to provide for themselves, to be able to provide that self-care. So it's allowing them to thrive rather than trying to figure out just how to survive. And I feel like that is our duty as an organization, as a group, of me recognizing, okay, I am chief wellness officer. I get to sit at tables that my colleagues don't. I have a duty. I have a sense of, a privilege to be able to have the ears of certain people in leadership. Therefore, and that is something that not everyone else has. So how do I utilize that to help uplift other people so that they can do what they need to do to take care of themselves? Because I am uniquely positioned to be able to do this. And then finally, again, I am a pediatrician at heart. The rules of the playground still apply at every aspect of your life. Treating each other with kindness and respect goes so much further than anything else, honestly, that we talk about. So again, I love this quote from Maya Angelou that many of you are probably familiar with, that people will forget what you said, they'll forget what you did, but they don't forget how you made them feel. And if you think about this from just interpersonal relationships, right? How many times do we say, that's not what I meant, or that wasn't my intention? Well, but there was an impact, right? And oftentimes that impact is a feeling that person is left with. So it really doesn't matter what you said or what you thought you were trying to do. That part of it that matters so much less than the result, which is, how did that person feel? And so the actions and the things that we say and the things that we do, if you're often thinking about, well, if by doing this thing, how might that make that someone else feel, as opposed to just objectively thinking, well, this is a good thing, this is a bad thing, but rather thinking about it a little bit more abstractly of like, by doing this thing, how might that make someone feel? That can guide you in how you are doing your actions. In fact, psychology shows that we end up making most of our decisions based off of our feelings, and then our feelings impact our thoughts, and our thoughts impact our actions, right? So this is another way that we can lead with purpose and with intention. So actually getting into organizational compassion. So by definition, what this is a proactive, systematic, and continuous identification of alleviating and preventing all sources of suffering. So we do this for our patients all the time, but how do we strengthen our organizational goals for our employees using this mentality? I often find, especially within the world of wellness, that we're often very reactive, right? And we're really good at crisis management. However, I'm trying to take many, many, many steps back and find out, why is it that this person is in crisis? Why is it that this unit is in crisis? What have we missed way further back that could have been potentially prevented? So rather than being reactive, how are we going to be proactive? How are we going to not react, but rather respond in certain cases? So if you haven't heard about wellness-centered leadership, this was initially discussed by Tate Shanafelt and his colleagues. And really what you think about is that there's this triangle, and it's kind of the thing about the hierarchy of needs. In compassionate healthcare and leadership, the base of it is that we care about people always. And that is the foundation of wellness-centered leadership. So you're leading not only with head, but you're also leading with heart, and you're balancing kindness with honesty, consistency, and courage. And honestly, I would just add to that, it's transparency. People know when you're lying to them. People know when you're hiding something from them. So presenting information in a way that is kind and transparent will get you a lot further, rather than sugarcoating it or trying to, soften the blow. So along with how we think about caring people always, we're giving people permission to be human. And that's one of the things that's really important that I really harp on when it comes to how we think about clinicians. Like one of my bone to pick is that especially around Doctors' Day, is when people call healthcare providers heroes without capes. I actually hate that, because part of that is that, does that mean I don't get to feel? Does that mean that I am somehow immune to feeling loss and grief and illness? As you can probably hear in my voice, I'm nursing a cold. Does that mean I don't have celebrations? Do I not have the same access to the full spectrum of human emotion as my patients do? And I think by putting people on that pedestal, somehow you're making it almost holier than thou, or even just that somehow they are immune to these things, and they aren't. We are experiencing the full spectrum of human life and experiences and emotions right alongside with our patients. So giving people permission to be human just allows people to just soften and just realize, like, it's okay for me not to be okay. It's okay that today I can't show up as 100%. I'm going to do everything I can for my colleagues and for my patients, but this might just be 50% is maybe just all I have right now, because I have so much else going on in my life. So how do we do that? We model and we maintain boundaries, right? We do that as leaders, right? And it's so important that so much of wellness-centered leadership is actually rooted in research that shows that leaders that are not tending to themselves, leaders that have a poor sense of professional fulfillment, end up, this isn't just I'll take one for the team. How you feel about yourself, how you are providing your own self-care, how you value yourself as a leader is going to have a ripple effect on the people who then report to you. So by staying up and sending emails late at night and doing work, you're not benefiting the team by doing that. In fact, you're directly harming them. They found that for every 1 hour less of sleep a leader gets, the people that report to them also sleep an hour, because that person's probably staying up late, emailing, corresponding, doing things. And that you're waking up and you're seeing an email from your boss at 3 o'clock in the morning, that incites a sense of anxiety for you and thinking, man, am I not doing enough? Is that the expectation for me? Do I need to be immediately available to respond to this, message or this email that comes through late at night after I've already, gone home and I'm trying to just live my life? That creates stress. And so by modeling and maintaining those boundaries, you're also letting people know like, hey, I'm respecting my time. I will respect your time. And now we are modeling that forward. So when we think about cultivating relationships, there's the individual relationships, right? And we know that people thrive in a workplace where at least 20% of their time can be kind of a passion project, in addition to the other things that they do. And then with teams, we know that people thrive with transparent and honest communication that goes both ways. So again, the next level is providing resources to manage work stress, letting people know like, hey, it's okay not to be okay, right? We heard about the amazing employee assistance programs in San Francisco, and we have one here that is purely confidential, and there is no record keeping, just notes for the therapist. It's available to people's partners as well. And that's important, again, to humanize the experience of like, hey, I get it. You probably have other things going on in your life as well. That's going to make it even harder for you to be present for your patients and for each other. And finally, how do we inspire change? So when I think about a leader who inspires change, this is a person who shifts the dialogue from you versus me or us versus them to us versus the problem. How do you invite people to the table and say, you're right, that is really messed up. That is really annoying. EMR is a huge pain. What suggestions do you have that we can try to make this better? So not only do they empower and nurture, but they also invite the challenge and say like, hey, yeah, let's talk about this. I don't have all of the answers, but you might have some suggestions. Let's hear it. So at various levels, here's what organizational compassion can look like. So we know from the healthcare worker, we know that people who are engaged, healthcare providers who are very engaged with their work have better patient outcomes, and there's decreased costs of care. We know that people who aren't burnt out, their executive function is better. They're not repeating labs. They're not working out of a sense of anxiety or scarcity of like, oh my gosh, what else could I be missing because I feel so scattered. So let me just in case, let me get this extra test, right? Which adds unnecessary hurdles for the patient and it adds unnecessary costs. As an organization, we're thinking about shifting from crisis management to prevention of negative clinician outcomes. But within that middle ground, right, which the middle manager, right, which I feel like never gets enough credit where it's due, it's that for leaders and managers is focusing on improving work conditions alongside the efforts that we're making to improve patient experiences and outcomes. So you're really kind of that fine balancing act of organizationally, what are we trying to do? And at the bedside, what are we trying to do? And at the heart of all this is compassion is at the heart of employee engagement. And we know that suffering is a salient clinician experience. We know that suffering is at the heart of what many of our patients are experiencing, but there's also the secondary trauma of being alongside that as a bedside nurse, as a physician, of also feeling that pull of like, why can't I make this thing better? And then that impacts us as well. So let's talk about the roses and thorns, right? The barriers and the facilitators. So some of the roses are that, a small act of kindness goes a long way. And that if we are able to focus on your celebration, win, or delight, as opposed to the horrible things that happened that day, that changes your view from a negativity bias to a positivity bias. Creating an organizational culture of caring for one another, and then the recognition of healthcare's emotional and physical impact. That we don't come through this unscathed, right? There's that quote that says that to think that you can walk through water without getting wet, or thinking that you can provide healthcare without being harmed by it is as unreasonable as thinking that you can walk through water without getting wet. And in terms of thorns, right, there's our own personal characteristics and experiences, right? We each have our personalities, we each are going through our own things, and we're bringing that to work as much as we try not to, right? There's systems within the issue. I can speak for the University of California. Oh my God, there's so much bureaucracy. There's so much red tape. It takes so long to get anything done. Things are very rigid and slow, right? So try as I might, I try to get one thing through and it takes months, and I have to just learn to temper my expectations about that. But this leads to stress, and that leads to things like burnout and emotional exhaustion. That's just part of what happens with this day-to-day kind of trudgery of what we're working with. And so how do we shift that mindset, right? How do I become more forgiving of it and just say like, okay, it is taking a long time to get these things through, but what can I celebrate as a win? What was one small thing that at least went well this week that's helping me move this needle forward, that this isn't all for nothing? That makes a huge impact for me in terms of how I think of my effectiveness. And if we're able to model that moving forward of, talking to our colleagues of like, yeah, it's really frustrating. Our patient's not getting better, but what can we celebrate today? Like what was one win that they might have had that we were able to provide for them that's still progress? So when we think about a higher perception of team caring leads to a higher perception of organizational compassion, and that improves general worker engagement. And so ultimately, why does any of this matter? Well, because when we show people that we value them, we create a sense of belonging. Again, it's that school spirit, right? Of why do I choose to show up at this place every single day? Why this place, not somewhere else? Right? So even when someone might be exploring an option elsewhere and they're weighing the two, and they're like, no, there's just something about being here. For me, it's the people at UC Davis. This is what keeps me here. I love the people that I work with at every level of this organization, in the ICU, with nursing, even administratively. And there might be really great people in other places, but they're not these people. And that to me is what gives me a sense of pride of like, everyone here is really invested in the community that we serve and the mission that we have. And I know that they're making an active effort to live out our values of kindness, trust, and inclusion. And that matters to me. So how do we welcome vulnerability? Well, there's different things like short-centered rounds, which rather than talk about kind of the process of what happened with a particular case, it's more of like, how did this affect you? Allowing for vulnerability, allowing people to say like, hey, I walked away from that code or that call night, and these are the feelings that kind of stuck with me. And being able to share that in an environment with other people who are creating a safe space for it. Similarly, that's what healing circles can do. We also have something like camaraderie groups, which we're expanding out from physicians to be able to include APPs. We're trying to have that within with our trainees as well, which really camaraderie groups are, we just get together for a meal. We've got one question that kind of brings us all together. And then from that one question, which often has to do with kind of your purpose in your chosen field, of like, why'd you choose medicine, or talk about a particularly happy event that happened with a patient, something that just brings you back to why we choose to do the work that we do. And we talk about it for 10, 15 minutes, and then we talk about literally anything else for the rest of the meal. And it's just a way of connecting with people within your department, across departments. It can be very easily done. It doesn't have to be a big to-do. It doesn't have to be a fancy dinner. It can also just be getting together, having one question that binds everything, and then exploring things from there. We have a peer responder program called Support You. Again, these are people who are trained in psychological first aid. They're not therapists, but they know the resources that exist at our institution, and they're able to just meet with someone similar to the coffee kind of one-on-one session of like, hey, I heard things have been kind of rough, or that sounds like a really tough situation that you were in. Do you want to talk about it? And just offers, what I call like listening delightedly to someone. And then finally, employee assistance programs, I think, are so key, and they show that the organization, the institution, is reducing the stigma of seeking mental health resources. So whether you have your own, whether you partner with a community organization, we have both. We have our medical society within the Northern California region that provides up to 6 free counseling sessions. So even though I tell people ASAP is totally confidential, some people just don't want to be at their home institution. They want to go elsewhere, and that's totally fine too. I'd rather you get the help that you need rather than suffer in silence. So putting compassion into practice, again, this is kind of going back to what Angelica was talking about earlier, but finding ways to connect with people. And this is so important. I think this cannot be overstated. One example, this is I got a grant to do my Med Improv workshop series at the Comedy Spot for UC Davis Health. And what the participants are doing is life story in a minute. So what you do is pro tip, this works great with loved ones as well. It's a much more enjoyable conversation than just how was your day. But you give someone 1 minute of your undivided attention, and you ask them to just tell you a story, whether it's their life story, whether it's about their day, whatever they want to talk about. You listen delightedly. Don't think about, oh, me too, or, oh, I want to connect with them. Nope, just silent, listen delightedly, let them have your undivided attention. And then after a minute, reflect back what you heard for a minute. I heard it, all of these things. These are the things that you shared with me. And then switch roles. Then you become the talker, they become the listener, and then they reflect back. And reflect on what did it feel like to have someone's undivided attention for 1 minute? How did that make you feel? What did you learn about that person? You may have known them your entire life. You may have just met them. But what did you learn about them that you maybe wouldn't have gotten had you interjected or tried to connect with them in the usual way that we do, or when you have a script kind of running in your head? Connecting with colleagues in a meaningful way. So this is things like, what was your favorite activity on vacation, rather than just like, hey, how was your trip? That is something that makes it so much more interesting, and it shows a vested interest in what that person has to say, and you'll probably remember it a little bit more, rather than like, hey, how was your weekend? Hey, how was this? That's also just boring. So how do we have more interesting conversations with each other? Acknowledging success as well as accepting gratitude. So expressing it and accepting it. And I need to do this more. Sometimes you can just say thank you. And that's the end of the sentence. Thank you is a complete sentence, just like we say no is a complete sentence, right? So when you're specifically expressing gratitude, I also invite you to share what they did specifically and the impact that it had, rather than just saying thanks for all your hard work. Because again, we also have we're really good at minimizing the things that we do and thinking like, oh, they're just being nice. But when you say thank you for doing blank, it really helped me by having this effect of blank. That person, then their brain's gonna have a really hard time trying to minimize that, because you just gave them evidence of what they did and how it was helpful. And that makes it something easier for them to take with them, and a sense of pride, and like, oh wow, they really were grateful. They did notice what I did. I'm so glad it had that impact. I had no idea. Or that was the impact I wanted it to have. I'm so glad. So as we conclude, I just want to invite you to show yourself some compassion. This is just a difficult time in general, and whether it's something personally is going on with your life, whether it's broadly things are going on, take the time to feel your feelings. Recognize that those feelings may change day to day, and then honor what you and your teammates are able and unable to do, and know that that's okay too. Tomorrow is a new day, and we will figure it out. We might come in with more energy, we might come in with less, and that's okay. We're in it together. Because it's important to realize that compassion becomes real when we recognize our shared humanity. And I truly believe that if we did that a little bit more with each other as a society, we would be regarding each other very differently. And recognize that we're all carrying our own invisible backpacks of things that we're not necessarily sharing with others, and just recognizing that humanity in another person, whatever feelings are coming up for you, if in that moment of irritation, seeing that person and recognizing that what they might be carrying will automatically bind you in this human experience in a way that, commonalities and things that we have in common may not, or that might not be overtly obvious. So with that, I thank you all and I wish you wellness. And here's my resources. And thank you for having me.
Dr. Sarah, thank you so much for helping us to conclude this time together. Despite our separation and gathering virtually instead of in person as we had planned, it does feel as though we've had a great opportunity for shared humanity for the last 3 hours. And I just am so grateful for the planning committee and their foresight on this agenda, for everyone who's been in attendance, giving us your time, and for the speakers and presenters who have spent the time preparing and then sharing what your expertise and your experiences have been. It really has created a really valuable and special time together. So thank you. And this has been a great way to set off HERO's 2 days of convenings. We are going right now into our think tank meeting on listening, which we've already been talking about today, and then a full day tomorrow of forum on the business case for kindness. I hope you'll be joining us. For those of you who are going with me into Think Tank, you have a different Zoom link to jump into that meeting, so we will zip over. And then also in October, we'll have our university virtual summit. So for all of you universities and academic medical centers, I encourage you to take a look as we continue this theme of how to be human together in this changing and trying time. for now, we are adjourned. Please complete the exit survey, especially if you want credit. I'm Karen Mosley, President and CEO. Thanks, and we are adjourned.